Բարև ձեզ, խնդրում եմ նստեք։ Նոթբուք։ Անջատես։ Բարև ձեզ։ Խնդրում եմ նստեք։ Գոլեգաներ, խնդրում եմ նստեք։ Մենք արդեն իսկ պատրաստ ենք սկսենք մեր կոնֆերանսը։ Ես բոլորին ողջունում եմ մեր գոլեգաներ, խնդրում եմ նստեք։ Մենք արդեն իսկ պատրաստ ենք սկսենք մեր կոնֆերանսը։ Տեխնիկական խնդիրներ ունենք, փաստորեն։ Ողջունում եմ մեր միկրոֆոնից ուսանք։ Ոնց եք լսում։ Տեսնենք ինչ ասում։ Ես սրանով եմ խոսում։ Հիմա արդեն տարբերություն չկա, լուծեցիք։ Ոնց եք ինձ լսում։ Նորմալ է, հա։ Դե գոլեգաներ, նախ ուզում եմ ասեմ, որ այսօր մենք հավաքվել ենք միջազգային երկրորդ կերատոկոնուսի օրը Հայաստանում կոնֆերանսին եւ այսօր շատ կարեւոր մի հատ բան, երբ որ մտնում եք ներս, խնդրում եմ բոլորդ գրանցվեք, որտեղ մենք ունենք կրեդիտներ տալու բոլորին, տալու ենք կրեդիտներ մեր նախ եւ առաջ մեր բժիշկներին, իսկ կլինիկական արձինատորներին եւ ուսանողներին իհարկե կտանք սերտիֆիկատներ։ Մի քանի խոսք ուզում եմ ասեմ մեր կոնֆերանսի մասին։ Նախ բացվել է հայկական կերատոկոնուսի ասոցիացիա, ավելի շուտ միություն, եւ մենք շատ բաց ենք բոլորի համար եւ ընդունում ենք բժիշկներ, գոլեգաներ, ովքեր ցանկություն ունեն ու հետաքրքրված են կերատոկոնուսով։ Կերատոկոնուսը համարվում է բավականին տարածված հիվանդություն, ամբողջ աշխարհում, եւ նպատակահարմարությունը ասոցիացիայի շատ մեծ է։ Նախ եւ առաջ դուք գիտեք արդեն, որ այդ հիվանդությունը շատ երիտասարդանում է եւ եթե առաջ երբ որ մենք սովորում էինք կլինիկական արձինատուրայում կերատոկոնուսի բուժման միակ մեթոդը դա եղջերաթաղանթի թափանցող փոխպատվաստումներ, ապա այո, այսօր կերատոկոնուսը բուժվում է արդեն շատ հետաքրքիր, շատ կարճ, էֆեկտիվ մեթոդներով, լազերային միջոցներով, ֆեմտոլազերային գործողություններով, կրոսլինքինգով, այսօր շատ հետաքրքիր բան ունենք, պրեզենտացիա ունենք, ներկայացնելու է ներկայացվելու է Smile Extra օրինակ գործողությունը, cross-linking-ի նորագույն մեթոդներ, customized cross-linking-ներ, accelerացված cross-linking-ներ, այսինքն կերատոկոնուսը արդեն իսկ բուժվում է եւ բացի դրանից որ բուժվում է նաեւ ենթարկվում է կորեկցիայի։ Ես ուզում եմ ներկայացնել ասոցիացիայի մեր միության բորդը, ես ունեմ կոպրեզիդենտ, այսինքն honored president, դա Աշրաֆ Արմյանա, իմ գոլեգան, ում հետ միասին մենք հիմնել ենք այս միությունը, ու մեր նպատակը նա է, որ մենք share անենք, այսինքն կիսվենք մեր փորձով ռեգուլար։ Երկրորդ բանը ես կուզեմ ներկայացնեմ ձեր գոլեգային Դավթյան Արաքսին, ով հանդիսանում է իմ կոպրեզիդենտը նույնպես, եւ մենք ունենք շատ մեծ հեռանկարային պրոյեկտ, դա լինելու է ազգային կերատոկոնուսի սկրինինգային ծրագիր։ Այդ ծրագիրը արդեն մեկնարկելու է 24 թվականից, քանի որ մեր ասոցիացիան արդեն իսկ հանդիսանում է միջազգային եվրոպական եւ ամերիկյան կերատոկոնուսի ասոցիացիա կերատոկոնուսի միությունների մի մաս։ Դա տալու է մեզ հնարավորություն այդ սկրինինգի շնորհիվ մարզերում եւ Երևանում իրականացնել տարբեր տեսակի վաղ կերատոկոնուսի ախտորոշման ծրագիր։ Դա տալու է իհարկե այն, որ մենք կհայտնաբերենք կերատոկոնուսը շատ շուտ։ Ուրեմն շատ լավ լուր ունենք, այս տարվա ընթացքում դուրս է գալու հայկական ժուրնալը հանդեսը, հանդեսը ակնաբուժության մեջ առաջի հանդեսը Հայաստանում, մենք արդեն իսկ հավաքել ենք հոդվածները, արդեն իսկ ժուրնալը գտնվում է տպարանում եւ մենք շատ շուտով իրեն կտեսնենք եւ այս կոնկրետ հանդեսը նվիրվելու է կերատոկոնուսին, բայց ինքը ընդհանուր, Eye Health Journal-ն է, աչքի առողջության ժուրնալն է, ու ինքը ընդհանուր ժուրնալ է, որը մենք բացենք, որ բոլոր մասնագետները, ակնաբուժները կարողանան իրենց հոդվածները տան։ Առանձին շնորհակալություն եմ ուզում ասեմ գոլեգաներ, մեր ֆարմայի եւ մնացած ֆիրմայի ներկայացուցիչներին, մասնավորապես Optinol, Siun, Get Farm, Leica, Human Optics, Bausch & Lomb, Dans, Alcon, PharmaPro, Demifarm եւ Liquor կամպանիաներին։ Մենք նաև ուրախ ենք տեսնելու մեր հետ այսօր Երևան քաղաքի գրեթե բոլոր բժշկական կենտրոնների ներկայացուցիչներին, դա իհարկե Շենգավիթ բժշկական կենտրոնը եւ Զիլֆյան Eye Care Center-ը, Սլավմեդ բժշկական կենտրոնը, Աստղիկ բժշկական կենտրոնը, Լավանդա կլինիկան, Գրիգոր Լուսավորիչը, Նայիրի բժշկական կենտրոնը, Ռեբունին, Ութերոթի Վանդանոց եւ Առաջի Իվանսի կոլեկտիվին, նաեւ Մալայան բժշկական կենտրոնի, Աչքի առողջության ինստիտուտի եւ իհարկե մեր կլինիկական ռեզիդենտներին, ովքեր որ այստեղ են, ապրեք, սովորեք։ Մենք նաեւ ունենք բացի նրանից, որ մեր կլինիկական արձինատորներն են բոլորը ստեղ, մենք նաեւ ունենք ստեղ մեր ուսանողներին, մենք համագործակցություն ենք անում արդեն Հայկական բժշկական ինստիտուտի հետ, որտեղ որ բացվել է աչքի հիվանդությունների ամբիոն եւ մենք արդեն ունենք նաեւ ուսանողներ, իրանք եթե ստեղ են թող ձեռք բարձրացնեն, այդպես արդեն կան։ Շատ ուրախ ենք ձեզ երեխեք։ Դե թույլ տվեք բացում հայտարարել եւ կխնդրեմ մեր Ռուբենին միացնի մեր կոնֆերանսին վերաբերվող վիդեոն։ Ընկերներ, շատ շնորհակալություն։ Don't tell us who? No. Շնորհակալություն եկեք ծափահարենք մեր պրոյեկտի։ Ուրեմն բացումը կոնֆերանսի կարող ենք համարել արդեն իսկ բացված եւ մենք արդեն ունենք ուղիղ միացում, ես խնդրեմ մեր հարգարժան պրոֆեսորին Hello Ashraf.
Hi Artishes, how are you? Good morning. Good morning.
Good morning. Ashraf-ը միացել է Եգիպտոսից, ինքը համարվում է մեր կոպրեզիդենտը եւ and we are very happy that you are with us and it's your time now. You can start your presentation, my dear friend.
Good morning, everyone, and good morning to Armenia. I miss Armenia so much. And first of all, I congratulate Professor Artishes for this huge work about Keratoconus and this great awareness. I'm happy that we are collaborating together for the huge country project that I wish to be kick off from Armenia to all the world, because you are a great professor and great scientist, Artishes, and I think we are going to start a huge project about Keratoconus soon together.
For sure, my dear friend. Just one few words. For translation, you need to take your headphones. Երեխեք վերցրեք նաուշնիկները, այն մարդիկ, ովքեր մենք ունենք սիխրոն պերիվոտ, ես մոռացա ասեմ, վերցրեք նաուշնիկները եւ դրեք այն մարդիկ, ովքեր կոլեգաներով, որ պետքա թարգմանություն. Okay, it's your time again.
And again, congratulations for the announcement of the volume 1 of the Eye Health Journal. This is a great turn in Armenia, and I think it will help a lot of young ophthalmologists to know about ophthalmology and keratoconus in deep science. So congratulations, Professor Artishes, my friend. So let me start my presentation. So let's talk about the new concept in keratoconus. So we know a lot about keratoconus, but the science and the future is bringing us a lot of new things. So artificial intelligence, as it plays a role in many concepts in ophthalmology. So keratoconus, I think it will be it's very important in the diagnosis and the early detection of keratoconus, which help a lot of people to regain sight, or even to prevent them from losing the sight. So I have no financial disclosure relating to these presentations, but these are my disclosure to companies that I'm a consultant and speaker to. So again, I'm happy that this is in the day of the World Keratoconus Awareness Day, November 10th, and it's coming from Armenia. Big project, a lot of cooperation between a lot of KOLs, leaders in keratoconus, and a lot of companies which are important in the keratoconus field, who are supporting this huge event from Armenia, from Yerevan. So again, what's Keratoconus Day? It's a global healthcare awareness event observed on the 10th of November every year to create awareness about keratoconus and support and advocate for those living with keratoconus. And on this day, several organizations, like in Armenia, companies, healthcare professionals come together to conduct screening programs, educational seminars, webinars to create awareness about its impact on people suffering from keratoconus. As me and Professor Artishes, we are going to create this huge program on the country level in Armenia. We should know that keratoconus was estimated to occur in at least 1 out of every 2,000. This is a huge prevalence in the individuals in general population based on the studies. However, better screening techniques indicate that it may be as high as 1 in 750 persons worldwide. Again, and this is a big number of disease that is happening in the world. It is estimated that about 5% to 30% of people with Down syndrome are affected by keratoconus. So World Keratoconus Day is celebrating to increase the awareness about keratoconus and its potential signs and symptoms. So this is a huge awareness should be given to the whole world.
You hear the term artificial intelligence.
Let's see
What
artificial
comes to mind?
intelligence and here and
Superpowered robots? Hyper-intelligent devices? Science fiction has familiarized the world with the concept, but outside of Hollywood, what is artificial intelligence and what can AI actually do? For starters, AI involves using computers to do things that usually require human intelligence. Humans can see with their eyes and process what they see. We can understand our environments and move around within them. Our brains have the ability to see patterns, and we have the ability to understand spoken language. Artificial intelligence is a broad branch of computer science that includes many different terms. In order for computers to achieve these capabilities, they require lots and lots of data. Large data sets allow AI algorithms to identify patterns, make predictions, and recommend actions. Artificial intelligence is already all around us, but today's best AI still can't compete with the human brain in some ways. For example, in 2016, the computer program AlphaGo defeated a legendary professional Go player. But if you ask that same computer to drive a car or walk or even play Monopoly, it wouldn't be able to do so on its own. AI's computing power is massive, but our human brains are able to tackle a much wider set of data and methods.
So artificial intelligence is not now, it is since many years, but it's developing year by year. So why we need artificial intelligence in keratoconus? This is a very important question. To diagnose grade keratoconus patient using deep learning, this is a term you should know, which is deep learning, on color-coded maps obtained from Placido disk-based corneal topography. While the diagnosis of clinical keratoconus had high accuracy, the accuracy was lower, 86.8% in subclinical keratoconus, and we needed 100% not to lose any patients. So artificial intelligence in general term that implies the use of computer to module intelligence behavior with minimal human intervention. Artificial intelligence is generally accepted as having started with the invention of robots. And the term derives from the Czech word robota, means biosynthetic machines used as forced labor. In this field, the general surgeons was faster than us. Leonardo da Vinci, lasting the heritages today, Bergering used the robotic assisted surgery, and most of the general surgeons using this technology nowadays, especially in Switzerland and England, even USA. Artificial intelligence described as the science and the engineering of making intelligent machines, and was officially born 1956. It's a very old, it's not a new. It is started, but it was very, very, very small idea. The term is applicable to the broad range of items in medicine, such as robotics, medical diagnosis, medical statistics, human biology, up to all including today's omics. So, if we look for the artificial intelligence in keratoconus, we have three main points: artificial intelligence, machine learning, and deep learning. These are three important words in the field of artificial intelligence. And it will going to solve the hidden layer between the input layer and the output layer. So corneal disorders are the world's, as we all know, the world's second leading cause of blindness. Keratoconus is relatively common bilateral corneal ectatic disease characterized by local biomechanical weakness. And this is what we are aiming now to see, the biomechanics of the cornea. As the disease develops, the weakening cornea becomes increasingly unable to resist the distension caused by the intraocular pressure. And now there is a measuring new concept in most of the machines of the corneal biomechanics between the IOP and the corneal biomechanics of the cornea. This may lead to the development of a cone-shaped protrusion that causes increasing myopia and irregular astigmatism. So artificial intelligence is early screening for keratoconus is important for laser vision correction to prevent triggering of keratoconus pathological process. And the development of keratoconus is influenced by both genetic and environmental factors. The environmental factors such as eye rubbing, which is nowadays highlighted by Professor Renato Ambrosio from Brazil since 2 years, and he is increasing the awareness by the Violet Awareness June, which is, we all now had the awareness that eye rubbing, one of the most important factors for increasing the progression of keratoconus. And the prevalence of keratoconus varies across different regions, ranging from 1 in 50 individuals in central India and to 1 in 2,000 individuals in the United States. So, in spite of the therapeutic advances, including cornea collagen cross-linking and intracorneal rings segments, patients with keratoconus are still an important group requiring corneal transplantation worldwide. And young adults and children are most affected by the condition. So moreover, the lack of consensus on how to define suspects, subclinical, and form frost keratoconus still persists. So this is the most important part we need from the artificial intelligence. So finding the appropriate level of sensitivity is essential to screen the mild and subclinical keratoconus, which is the most important part in artificial intelligence, because if it's keratoconus, we all can diagnose keratoconus, but we need to see what is subclinical keratoconus or what will come to be a keratoconus patient. So if we look to the machines, you can see that how it started since 1994. They started to put data in the machines so they can use the artificial intelligence to diagnose early keratoconus. And the Orbiscan in 2010 develops a huge change in the Chinflu camera Placido done by Renato. And then it improves. Also increased again in 2016, the Placido topography and corneal wavefront, and more improvements till we reached now the Ambrosio et al. That the Chinflu image topography and the biomechanical data. So it's improving from 1994 till 2020, and now in 2023 there is a new development. I think Renato will talk about this in more details about the new innovations in the biomechanical detection of early keratoconus. So again, two important words in artificial intelligence: the machine learning, you put the data for the machine, and the deep learning. So artificial intelligence provides a state-of-art assessment of the indices of the keratoconus, both the traditional based on the artificial intelligence used in early detection of keratoconus. So you put the data, input, the feature extraction, and then classification by the machine, and you then get the output. It is a keratoconus or non-keratoconus. But more deep learning with the inputs, increasing the feature extraction, not just the classification, it's a feature extraction plus classification, give more better detection of early keratoconus, and this is through the artificial intelligence. And if you look like this is a huge scheme. I cannot understand a lot, but this is how the whole machines, the OCT, the Corvus, the Pentacam, you put data for all machines, and you just scan the patient, and you got the results. So again, by the machines, the new OCT modules and the Corvus and the tomography and the pachymetry, you can detect abnormal and the suggestive of keratoconus before it happens. This is the most important from the threshold of different devices. Is the Placido disc-based corneal topography have an artificial intelligence? Yes. The importance features of the 4 devices, the Orbiscam, the Pentacam, the OCT, the whole OPD, all this nowadays have a new software of artificial intelligence, the Orbiscam 2, the Pentacam XAXL, the Wave 4 maps, refractive display, and the Bellin Ambrosio enhanced excessive displacement. And also they add the Galilei G4, the new machine with the axial map series, the lowest part. So all these machines nowadays have a new software, and I think by the end of 2023, the old machines will will give us the new software for artificial intelligence for detection of early keratoconus. And if you look to the Placido, the artificial intelligence in the Placido disc-based corneal topography, you can see how it's looked normal, inferior steepening, irregular cornea, and this is just by the Placido. So artificial intelligence was also used to diagnose and grade keratoconus just by the Placido, but it was only, as we said, 96.8% accuracy, but we need to reach the 100%. Not to lose any subclinical patients. Also, artificial intelligence nowadays is already on the Orbiscam, the new Orbiscan software, and it is developed day by day, reaching now 95% accuracy rate in classifying the normal from the keratoconus. And this is the new Orbiscam software. By the Pentacam, also improved the accuracy, and this is the new, now differentiate. The difference in the results might be different between the keratoconus stages, and this is with the new software of the Oculus that it will be released, I think, during the ISCRAS in Barcelona. They are going to announce the new software with the artificial intelligence. Also, the Galilei, as we said, has a new software, and it's called the Asphericity Asymmetry Index. And this is the new software that will be shown by the Galilei, and it gives up to 97% accuracy in diagnosis. Also, the Schwinn Cyrus will going to have an artificial intelligence software, new software, exploring the additional techniques and the larger database that increase the quality of the suspicion of detection of keratoconus. The OCT and the epithelial mapping, it's going to improve also by the end of this year, and the deep convolution neural network based on the anterior OCT was able to identify diverse cornea diseases, including the cornea epithelial defect, epithelial thickening, and the cornea thickening. And this is the new software. Do we can combine the spectral domain OCT and the air puff? Yes, this is also the new, I think maybe Renato will going to highlight, because there is a lot of papers now going to be published soon, comparison between the picture of the spectral domain and the air puff tonometry. comparing the pressure of the IOP, the corneal biomechanically, and how we can detect keratoconus before it happens from both the intraocular pressure and the corneal biomechanical. Also, as I said, that the corneal biomechanics in the new software that is going to be published by the end of this year, it's going to change, may proceed the topographic changes, and also the biomechanics was proposed for early diagnosis, and these are the new software machines that I am showing in this, how the new Oculus, and also it will going to be highlighted, I think, by Renato in his talk. The aura is improving. Yes, the aura is improving nowadays, and included a new software for artificial intelligence, and it has to detect the early form of frost keratoconus by the aura machines. There is a lot of factors in the detection of keratoconus, and all these factors can lead to keratoconus: the LASIK, the epiLASIK, the small incision smile, intracorneal link, corneal cross linking. All these will going to change the corneal biomechanics. So you should know that if it any happened from refractive surgery, you should early diagnose that the patient will going to provide going to go for a keratoconus cornea, and you should treat as early as possible, and should relate also. They are relating now artificial between the glaucoma patients, the systemic diseases, the hormonal changes, the genetic changes, intraocular pressure, to the corneal biomechanics to detect the early keratoconus. The Corvus, which is the new machine for the cornea biomechanics, and the CPI and the TPI were designed to diagnose keratoconus, but now they are going to give more data for the Corvus to be more and more sensitive for early keratoconus patients. This is how they are going to apply the artificial intelligence to the Corvus. There is another recent Nobel study that the optimized tomographic biomechanical index group was analyzed with two different random forest algorithm, and this is the new software, and they are considering that the new TPI, the BAD, and the CPI is going to change a lot in the accuracy and sensitivity that can reach up to 96% detection of early keratoconus. The new is the Brolin microscopy. The new microscopy, the Brolin microscopy. This is the new artificial intelligence that can detect early interaction of the laser light, and it is a spontaneous acoustic phonons within the material, and can reveal mechanical qualities like elasticity. So it's not only biomechanics, it's only elasticity of the cornea. And this is the only machines now, the Brolin microscopy, that can have strain stress index. This is the new word, the strain stress index maps that recently developed to evaluate the geographic change in the biomechanical stiffness across the corneal surface. So it's not only biomechanical changes in the stroma. No, they can also now detect the strain stress index. So to finalize, yes, I also want to show this, that the Topo Eye artificial intelligence application, it's a new machine. It's very cheap, but can detect a lot of changes in the artificial intelligence with keratoconus. So my take-home message: the more accurate keratoconus detection requires both clinical judgment enhancement and improving the quality of the machine's learning algorithm. using artificial intelligence in genetic and markers evaluation and longitudinal corneal data may predict future disease. When developing such approaches, it's essential to select the relevant and the appropriate parameters combination from larger parameters. I just highlight this Keratoconus book that have a lot of big data even in the genetic part of the Keratoconus. Thank you so much for being here, and thanks Professor Artiches for letting me be in this huge event.
Thank you very much, dear. It was a wonderful presentation. I just want to have a few questions. First of all, do you practicing AI in your clinic, and which equipment you prefer more? Because you show many diagnostic tools like topographers, analyzers. Which one you prefer more? For now, because it will, of course, for now.
In my clinic in Egypt nowadays, I have the anterior OCT for the epithelial mapping. We have the aura for the cornea biomechanics, and also we have the Corvus, not in my clinic but in another place that usually I'm using now to detect the early keratoconus in refractive surgery. So you cannot, if you found any suspicious patient coming for refractive surgery, you should use all your tools to detect if this patient is going to develop a keratoconus, if the cornea is touched or no.
Thank you very much. And we are going to next session, next presentation, please.
Susan, she will present issues in keratoconus treatment and
Susan Jacob, you are welcome to Armenia. Thank you very much that you are with us. Can you?
Hi, Susan, do you hear us?
Hello, can you hear me? Am I audible?
Yes, we are hearing you. Yes.
Hi, Susan.
All right, that's great. Hi, Ashraf. Wonderful talk as always.
Thank you.
So, thank you so much. I had a little bit of an internet problem, I think, in between, but I'm glad to be back online. And thank you, Diana, and all the other organizers of this Armenian conference for inviting me here. It's really a pleasure to be here. My talk is on CARES. I will just share my screen if you give me a moment. Okay. So, 1 second. Yeah. CARES stands for corneal allogenic intrastromal ring segments. And this is basically a technique that had started around 2015. And we've been doing many cases since then. And we've got lots of publications also online. And also many other people around the world, doctors have also started doing this technique. I'm very happy to say. These are my financial disclosures. I do have a patent pending for special refines, devices, and processes used to create these segments. And I'm also working with Madhu and Zymer Ophthalmics. So when you talk about keratoconus, the reason that it's important, and I'm sure many of the speakers before me have already talked a lot about it, is because the overall incidence is really, really high. So it's much more than we previously used to think about it. All right. I think, can you see my screen?
Yes, we can see everything is fine. We can continue.
Okay, fine. That's great. So, yeah. The incidence is much more higher than it was thought to be. There was this very good study in Riyadh, Saudi Arabia, which showed that the incidence was about 1 in 21 patients. And in Central India, there was a study which showed an incidence of 1 in 43 patients. So these are really high numbers. And around the world, there is, of course, a geographic variation in the incidence, but we found that overall the incidence is much higher than we thought it to be. And it's also a disease that affects young people who are active in their life and, who have got the whole working life ahead. So it's really important that we treat this disease early, prevent it from progressing, And in those patients whom is already progressed, we regress it so that they're able to get their best potential vision and are able to carry on with their life. So that's the reason this is really a great initiative to have this Keratoconus Day and the Violet June. And I'm really happy that Keratoconus is getting the attention that it deserves. When you come to the treatment modalities of keratoconus, basically you can classify them as those that have invasive treatment modalities such as optical penetrating keratoplasty, DALK, small aperture optics, RLE, which is refractive lens exchange, phakic lenses, and so on. And you can have, on the other hand, minimally invasive such as CARES, CXL, ICRS, topography guided PRK, and so on. Now, obviously, it always makes sense to go in for a minimally invasive procedure before you go in for an invasive procedure. And that is what we are going to be talking about. But before we go to CARES, I'd just like to show you a small comparison between the different kinds of minimally invasive procedures. So if you take corneal rings, and if you take topography guided PRK, these are probably the most popular treatments which are there for mild to moderate keratoconuses. And CARES is a type of corneal rings, but I'd like to say that it actually has much more effect than the conventional synthetic corneal rings. So, however, because it does fall in the classification of corneal rings, let's just compare these two techniques and see what are the differences, the advantages and the disadvantages. So what is the mechanism of action of corneal rings? It's much more physiological because, you know, it's kind of just an additive technology. You're putting in substance there, either in case of synthetic ICRS like Intacs, you're putting in PMMA, or in case of CARES, you're putting in allogenic tissue. Whereas when you're talking about topography guided PRK, you're basically doing the same treatment as the cause of the pathology. So whatever caused the disease, you're basically doing the same treatment. So it's not completely logical. Of course, you can have great outcomes, but the problem is you might have the potential of destabilizing the disease. And this is the reason it's combined with CXL. However, we know CXL does not harden the cornea into plastic. It still increases the stiffness by about 3 to 4 times. And so if that is not sufficient for the particular patient from where tissue was just removed, it's possible that the patient can destabilize and progress, whereas that can never happen with corneal rings. It can progress only with the natural progression of the disease, not because of the treatment that you've done. About the effect on pachymetry, again, CARES thickens the cornea, whereas topography-guided treatment actually thins the cornea. When I say topography-guided PRK, obviously it also means with CXL. What about the effect on progression? The CARES and other corneal rings have a false limbal effect. They are having increased the thickness of the cornea. So the outcome of progression is actually decreased, whereas in case of topography-guided PRK, there is no protective effect at all, and there's possible deteriorative effect. The magnitude of effect, how about that? So with CARES, you can have large amounts of effects. As I'll show you, you can have even up to 30 diopters, much more larger than even synthetic ICRS will be able to give you. But with topography-guided PRK, you cannot get these kind of large outcomes, because then it becomes dangerous and you'll definitely end up destabilizing. So the kind of patients that you can take for topography-guided PRK are those that have mild disease. Again, in the combination with CXL is desirable in corneal rings, but of course it's essential in topo-guided PRK. And we also know that rings plus CXL, the incidence of haze is just as much as with CXL alone. But when you do PRK and CXL, the question is there possibly an increased risk of haze? So basically, when you look at it, corneal rings is a much more sustainable treatment in the long term. And so let's see how it has evolved. The synthetic segments were the ones that were being done, but they were leading to problems such as intrusions, extrusions, migrations, melts, corneal melts, again, even progressing to infectious keratitis. There were reports of the segment intruding into the anterior chamber and causing acute eye drops and so on. So I got this idea about putting in allogenic implant instead of these plastic segments, and we published a series in JRS. And when we say allogenic, it could refer to any source of allogenic tissue, preserved, processed, in basically any source. But currently, of course, what we are using is the donor corneoscleral rim. So this is what it looks like. Natural implants, if you look at the cornea pictures, you can see various different types of segments here. This is almost a 330 to 360 degree segment, which means it's almost circular, and you can see the thickness that has been implanted. Again, when you compare it with ICRS, if you look at the cross section also, you can see that it's in mid-stromal implantation. And with this amount of thickness and mid-stromal implantation, you would never be able to do it for Intacs or Kerra rings or Ferrara rings, any of the synthetic segments, but you can do that with the CARES or allogenic tissue, which is a huge advantage of this technique. So thereby you can get a greater effect for your patients. You can implant them superficially, again adding on to a greater effect. You can put them in a smaller optic zone, which again adds on to a greater effect. And all these three advantages allow you to get a much greater effect, being able to thereby tackle very advanced keratoconuses also, and being able to avoid a DALC in many cases. The incidence of glare and halos is also much less, because you're using allogenic tissue and not synthetic segments from which light can bounce off. The risk of complications is much less, because again, it's allogenic tissue. It's highly customizable, as I'll show you. And the big advantage is there's no need for a large inventory or FDA approval. In addition to that, as in any rings, it's reversible, adjustable, and redoable. And one big advantage of CARES, as I already said, it's not just the advanced cases, but also the very early cases that you can use to treat with CARES. There's no need for long-term steroids. It gives a great outcome cosmetically. It's biocompatible and biointegrable. And in addition, it does not take away the ability to perform any future surgery or additional surgery. So let's just look at how you would do this procedure. If you'll just give me a minute. Yeah, I'm sorry. So I'll just show you this video first. All right, so how would you do this? This is how we do it. We remove, in case you're using the donor cornea for the allogenic source, you remove all the epithelium, and then you remove all the endothelium, because these are not layers of the cornea that you want to implant. You basically want to implant only the stroma. This is a double-bladed refine, which has two circumferential blades, as you can see here. And you take that and punch the corneal tissue. And what happens is both the blades cut at the same time, and you get this ring of tissue that is there in between the two blades. So this is then marked. The Bowman's layer side is the one that you saw facing you. So that is marked with a surgical marker. And then you cut it into whatever segment size that you want. In this case, we've given one cut through the center, and we flatten it out and we lay it on the side, so that what happens is the width of the tissue that was cut now becomes the thickness that's going to be implanted. This is a CARES customizer that I have designed. And you can see all the radial zones as well as the clock arcs as well as the optic zones are marked out on this CARES customizer. And now what we plan to do is basically customize it to the patient. Now, in some patients, you could use uniform thickness CARES like standard Intacs or standard Kera rings. But in other patients who require customization, and many of them do, you can easily customize it. So what you do is you draw the plan on the patient's topography map, and then you place a segment on the CARES customizer and mark it according to the topography. And you can easily, very easily, in a matter of few seconds, cut it according to the desired topographic plan that you had put. Now, I've already marked the 3 and 9 o'clock positions in the sitting down position, so that you have accounted for keratoconus. Then you mark the corneal light reflex, and then you mark also according to the plan, the marks on the corneal surface of the patient. The femtosecond laser channel is already dissected. You can see how easy it is to put in. So there you go. This is just tissue that has been freshly cut. Let me show you that again. Tissue that has been freshly cut, and you go in, put it on the cornea. Use this Y. It's a curved Y, and these instruments are available with epsilon. I do not have any financial interest. These can just easily be pulled into the femtosecond laser dissected channel, and you can see in a matter of few seconds you've already implanted the customized CARES, and it's nicely in place. So this is basically how it is. If it was a uniform thickness CARES, it would have been just lying in a position in one place, but in customized CARES, it should have been uniform thickness all around, but in customized CARES, you can see how the thickness varies according to the plan. So this is basically a uniform thickness CARES, whereas this is a customized CARES. And you can see here, you want a kind of a uniform flattening above it, but here you want a gradation in the amount of flattening you need also, so that you get a greater flattening here and a lesser flattening here. And that this kind of customization allows you to give that gradient of flattening that you need. So here's again a customized CARES that has been put, and you can see how the flattening also has a gradient, and the gradient follows the shape of the CARES segment that has been implanted. So again, just an animation showing you how it's done. You have the double-bladed refine. You cut the donor cornea from which epithelium and endothelium has been removed. You mark the Bowman's layer on the refine, and we have just written about this Bowman layer marking. We've submitted to Cornea Journal, and it's got accepted and should be coming out soon. And that's a very important point, because you want to be sure about which side you're going to be putting in. You want to know for sure that your Bowman's layer side is lying towards the pupil, and that there are no twists in the cornea, and for that this helps a lot. So here's the CARES customizer. This is the optic zone clock cover. which we are marking according to the plan that was put, and then we easily customize it. It's really, if you as an ophthalmologist, you can do phaco and you can do lenticule extraction and things like that. This is really nothing. It's really simple. So the another big advantage of the CARES technique is that it has a really low learning curve, and you can easily do this technique in your own clinic. Different types of customizations are possible. That's another big advantage with CARES. And of course, CARES alone is not the answer for patients who have got progressive keratoconus. You also do need to combine with cross-linking. So remember that. And in patients who have thin corneas, you can just do a contact lens assisted cross-linking, with which we've got now many, almost 9 to 10 years of experience, with a very low level of progression and a very safe procedure with no scarring, no endothelial loss, and no haze formation post-operatively. So you combine it with cross-linking, and then you go ahead and do your customization and implant it. So again, here's how you translate the plan. You mark the plan on the patient's topography. You put it on the CARES customizer. You mark it on the CARES segment, which was initially cut out with a double-bladed refine, and then you just cut the customized CARES into shape. You mark the same points on the patient's cornea, and then you implant it, and then you see that it exactly corresponds to what you wanted. So as I said, Bowman's layer marking is important, and that's because you don't want to twist when you insert it. This is transparent tissue, so you want to be sure, and that having that mark on the Bowman's layer side really helps you to be able to do that. In addition to that, one second, this is blocking my, okay. In addition to that, here you can see, again, you can have twists in various different ways, and this really helps you to visualize and put your tissue in well. So these are the instruments that we use. This is the double-bladed refine, which is available from Madhu Instruments, Madhu Surgicals India. And this is the Jacob CARES set, which I've designed. And this has every single instrument that you would need to do this procedure. And it's available with Epsilon. And we also have nomograms, which help you to kind of customize and determine what kind of segment you need to put in which patient. And for anybody who's wanting to start off with CARES, please feel free to email me. I'll be very happy to help you start off with the initial planning and things like that. So now again, if you look at the advantages of CARES over Intacts, you can see that Intacts or other synthetic segments are not indicated if the keratometry is above 58 diopters. So basically you've removed the benefit of this procedure from many patients who are above 58 diopters. We know that when we see patients in our clinic, there's a large majority who are much more steeper than 58 diopters Kmax. If you cannot do CARES for them, then what is the option for them? That leaves just a straight DALC. And you really don't want to do an invasive procedure like a DALC for these patients, because DALC is, has a much higher risk of complications than a simple procedure like CARES with CXL. And also DALC is an irreversible procedure. Once it's done, it's done. So also in patients where in the zone of implantation, the thickness is less than 450 microns, again, you have the same problem. You cannot put synthetic segments. And also in patients where the pupil size or the pupil diameter is larger than 6 millimeter because of the plastic leading to internal light reflections, in all these cases, synthetic intracorneal rings are not advised. Now, but these are cases where CARES does beautifully because it's allogenic tissue. So you can implant it in corneal diameters less than 6 millimeters. I mean, pupil diameters less than 6 millimeters in areas where the thickness is less than, there's actually no limit for thickness. I've done it for in areas where the thickness is only 232 microns. In fact, it's a huge advantage because as I'll show you, in fact, I'll be showing you that case now. So you can do it with really thin corneas also, as long as you can combine it with cross-linking. And you can do it with steep corneas as much as 90 diopters. I've done it. So another big use of CARES is where you have corneal melt secondary to cross-linking, where you can also use it to treat. Here's an example of a patient where you can see a thick CARES segment put, and you can see how the segment is actually filling up the whole cornea and creating compression anterior and posterior to it, and giving you an improvement in the shape of the cornea, causing centralized flattening from the cone that was previously there. And you cannot put this size of a synthetic material into the cornea, obviously, because it's definitely going to cause problems, and you could not even think of putting it superficially. So CARES has huge advantages by giving you greater effect. You can have about 20-30 diopters of flattening with CARES, whereas in synthetic segments, you cannot hope to have that amount of flattening. So as I said, you can also don't have any complaints of halos and glares because it's allogenic tissue and does not cause internal reflection. So this is the patient I was referring to when I said that even in patients with very, very thin corneas, you can really go ahead and do CARES. This was a patient who had undergone a TG PRK, topography guided PRK with cross-linking, and he had progression a couple of years down the lane. And when his topography was seen, his pachymetry showed a very thin cornea of only around 232 microns in this localized area. So what we did, you wouldn't be able to do anything else for this patient other than a DAL with that amount of thinning. But what we did was we put in a care segment into that area. And because CARES is allogenic, it's going to integrate very well with the cornea above and below. So we put in CARES, and the advantage that it gave is it also actually thickened the cornea in this area, by which we were then just able to proceed easily with cross-linking. Cross-linking also became safe, and this patient did very well post-operatively, and we avoided a DALC for this patient with good visual outcomes. As I said, CARES is now being done in a large number of patients in India, in USA, in multiple centers, in Lebanon. Shadi Awad is doing many number of cases, and he's got a large series also. Germany, Australia, Canada, UK, South Africa, Turkey, the list just goes on. France, Dominican Republic, Israel. And indications not just keratoconus, but also stable keratoconus, not just progressive keratoconus, but also stable keratoconus. You can use it for other corneal ectasias, as I'll show you, for PMD and for post-classic ectasia. And you can also use it for treating synthetic segment complications. So this is something that if you're doing ICRS, or if there are other surgeons or other people in your country who are doing ICRS, you might sometimes come across complications like this, where the segment has melted and come out. And CARES is a beautiful way to treat these kind of problems, because you can just cut the tissue, measure the amount that you need, and just insert it into that defect from which you just remove the segment. You obviously cannot leave the synthetic segment like that, because that would have caused infectious keratitis. But CARES acts beautifully to not just help the topographic stabilization and improvement, actually, as I'll show you, but also to fill up that defect after created after removing the intacts. So here's some examples of postoperative patients where we have removed the intacts and we've put in CARES. This is with the sutures still in place and with the sutures off. And you can see beautifully CARES on one side and intacts on the other. A second patient, again, CARES on one side and intacts on the other. And you can see this was the area of melt where the CARES has filled it up all the way up to just under the epithelium, the new freshly grown epithelium, of course. But in these two areas, in the two extreme ends, CARES has actually been pushed into the tunnel where the melt had not yet gone. So you can see the level of CARES here in this scan across, where you can see part of it is in the tunnel, filling up the tunnel and giving you that flattening, and part of it is also giving you that filling up of the stromal defect. Here is the pre-op topography of this patient. This is post-op. And you can see when we remove the intacts and we put in the CARES, we actually got a much better flattening. So it was not just saving the patient from a disastrous complication, but also that we improved his visual acuity and his topography also. We also published this with Shadi Awad in the Journal of Refractive Surgery in 2022. So here is a pre-op and difference map. And these are the Scheimpflug images. If you see here, this Scheimpflug image, you can see is a beautiful way to show the patient as well as understand for yourself how much difference CARES can bring about. This is pre-operative, and we've actually superimposed the post-operative along with it. And you can see the amount of flattening that we've been able to get just by putting in CARES, even up to 30 diopters, as I showed you. And so you can really get away from doing a DALC in many patients. Again, if you look at this topography, if you look at the values, they're all over the place, 72, 58, 66, 59. But if you look at post-operative, they're all on the near normal range, like 44, 41, 47, 52. So really, this is a huge improvement in the patient's topography as well as vision. And it's not just for the advanced cases, which I showed you, like it was not just for these cases that you can use CARES, but you can also use it for mild cases. So here's a CARES that is being implanted, aiming for low effect. And you can see we've got just an effect of about 3 to 4 diopters of flattening, because that's all we needed in this case. Whereas here's a patient where we needed moderate to large effect, and we've got 10 to 12 diopters in this case, because that's what we needed here. And then as you've seen in the previous case, we can even get up to 30 diopters of. So you can customize it a lot depending on how much you want it to be. You can also put 330 or 360 degree CARES, as we've been doing, and getting great results with that also, and getting good topographic stabilization. You can put single segment CARES just on one side, and that will give you the flattening above it and a compensatory steepening on the opposite side, which gives you this overall regularization as seen here post-operatively compared to pre-operatively, as well as a centralization of the cone. You can put asymmetric cones, thicker one and thinner one on the other side. You can use CARES, as I told you, for PMD also. This is the pre-operative map for this patient. This is post-operative, and you can see how regularized it's got and how it's come to all normal values, with the crab claw appearance really decreased so much, and over the pupillary zone it seems to be almost uniform everywhere. And you can see also the flattening that we got literally actually mirroring the PMD pattern with a great amount of flattening in the crab claw pattern as well as a steepening in the previously flat area, giving you this regularization. This patient had a preoperative coma of almost 6.629, which is a huge amount, and we managed to get it to drop to 1.8, which obviously led to a huge improvement in the visual symptoms of the patient. And if you look at all the peak to value and all these other values, you can see that all of them dropped dramatically and the patient really did very well. Here's another example of a PMD case where we did CARES and the patient had a great improvement in their vision. Intacs explantation with CARES is another thing that you can do. Patients who are not happy with Intacs for multiple reasons. Either they're not happy with the amount of visual improvement they got, or sometimes they might have some complications, or sometimes they even, this particular patient also felt his Intacs. Basically, it might have been impinging on a corneal nerve. We don't know why. He's neither happy with his vision and he was also not comfortable in his eye. So we decided to explant it and we put in a CARES, and you can see what we've done. Both of them have been explanted out. You can see the ghost channel left behind here, also the ghost channel here. And what we did is we created a more superficial channel with a smaller optic zone and inserted a CARES there. And that gave us, again, preoperative for this patient, post-operative for this patient, and the difference map. So we were able to get a much better effect for him following the explantation of Intacs with the implantation of CARES. So here's another case where we did the same, where we've just explanted that Intacs, as you can see. And once we've explanted it, I'll run through this video. We made a new channel for him. And into the new channel, we go ahead and put in this CARES segment. And you can see this is a freshly cut CARES segment, and you can see how easily it will go in. So I'm just demonstrating the segment for you. You use these curved instruments, just kind of push the initial part in. And once that's gone, that Y acts like a fork, literally just leading it along. And once you've gone a certain distance, you can use a reverse sensitivity from the other side to just pull it into place, and you can get your whole segment in. So you do get asymmetric synthetic segments, but if you look at these segments, they're uniform. There's a uniform change in the thickness from one end to the other, or there's a uniform change in the width from one end to the other. And also they're available in fixed optic zones, fixed diameters, fixed thickness, fixed arc length, and everything else about them is fixed. So that's not really true customization, whereas with CARES, you can get exquisite customization, because you could have a patient where you want a larger length of the uniform thickness part and a small taper. You can do that. You can have a different length of the uniform thickness, a longer taper, you can do that, a very short taper, medium taper, a broad edge taper. So there's so much of customization, as I showed you in the previous animation also, that can be done. These are all various different shapes that you can do, which obviously cannot be done with synthetic segments. And you can see how we are able to get exactly mirror the type of flattening that we want using different kinds of customized CARES. So these are all different examples of customized CARES, and you can see here the central taper, and you can also see how the central taper is associated with the less flattening in the central part. As I already gave you one example, here's another example of decreased coma. In almost all patients, you get decreased coma, and thereby the visual acuity improves. So here it's the drop from about 3.438 in the 6 millimeter zone to about 0.350, which is again a huge drop by about 10 times, and obviously leading to a much happier patient. It can also be used for post-LASIK ectasia. Here you can see pre-op and post-op on the left-hand side, and again a decrease, a flattening and an opposite compensatory steepening, which has led to the regularized area over the pupil, and again a decrease in the higher order aberrations and improved HOAs. You can adjust CARES much later as well. This was a patient who came about 1.5 years later. What we wanted to do was we wanted to adjust it a bit, because we thought that we would be able to get an even improve its effect further. So we went in. Then remember, this is a 1.5 years later, and I'm showing this video just to show you how it is possible to adjust these even so long later. So we've gone in, opened up that old channel, just kind of we've gone around the segment to loosen it up a bit, just as you would do with, for example, if you've got a failed DSEC graft and you want to remove it, and then we were able to bring it out. So the initial loosening is important, because just by pulling alone, it won't come up. You have to just go around the segment, loosen it. We wanted to decrease the amount of effect we got, because we thought that it was slightly an over effect. So we cut it and then we put it back. In fact, this patient is back in the outpatient department today to see me, and he's a very happy patient. And I have the updated topography, which looks even better than what you see here, where already you see an improvement. So his adjustment was possible 1.5 years later with an improvement in vision from 5/60 to 6/36 pre-adjustment. This was pre-CARES 5/60. Post-CARES, he had come to 6/36 part, And post adjustment of the case a year and a half later, he improved to 6/12 part uncorrected vision. So CARES versus DALK, you can avoid all these complications and do CARES in much more advanced cases as well as, and you can also, it doesn't take away the ability to do a DALK in case you have a patient with a progression. You can still always do a DALK later. So if your CXL has not worked enough, you can just, go ahead and do a big bubble DALK as you saw here and just successfully do a DALK. So it doesn't take away your ability to do any other procedure. And also these segments remain stable over time, as we've seen over 5.5 years later, 6.5 years later, they remain stable. And this slide is courtesy Dr. Rohit Shetty, who gave me this confocal microscope image of a patient with CARES. And you can see that there are these healthy keratocytes which are still there, which are possibly secreting collagen even now. None of them are showing myofibroblastic transformation. So is that also a possible reason why the CARES segment does not thin out with time? Is it because of the cross-linking that's done with it? We really don't know the answer to that, but we do see that it doesn't thin out. And basically this slide from Dr. Rohit Shetty really helped to show that. So long-term stability, again, we've seen it over 4 to 5 years, in fact more, because now we've got about 8 years of follow-up. Visual axis is clear. That's one big advantage over other adhesion keratoplasty techniques, because we are not operating on the visual axis. So any kind of haze which could potentially form in the segment, if any adhesion keratoplasty is kept over the pupil, it could lead to a loss in vision, even at the minimum a loss in contrast sensitivity. But CARES doesn't affect any of that because it's placed in the mid periphery and not over the pupil. It's cosmetically, it looks great. As you can see in this patient's eye, you cannot really make out that he's got a segment implanted. And the rate of rejection, even with a DALK, is only 14%. So CARES is even more low, with huge number of reasons why the incidence is so low. It's only about 0.25% or something. But the best part is, even if it rejects, it doesn't matter because it's in the mid periphery. As I just said, it's not lying over the pupil. So to conclude, it's a very, very useful technique, and it's non-invasive, biocompatible, safe, highly effective, titratable, reversible, adjustable, and a very low learning curve, which is the best part about it. Unlike other subtractive procedures, it adds tissue to the thin keratoconic cornea, making it a safe procedure. It's much safer than plastic inserts. It's safer than keratoplasty. And so this is really something that we should offer to our keratoconus patients as a way to improve their vision. With that, I'll end my talk. Thank you so much.
From hearing of the great results, we have a question. Because CARES represents adequate tissue
Okay, I am sorry, but I couldn't hear anything. I'm not sure if Ashraf, could you hear?
No. I think the mic is not good. Can you change the mic? This is not a good mic.
If it was a question for me, I'm sorry, I couldn't hear it at all. However, if you were just going to the next question, thank you so much.
And now do you hear me?
Yes.
Better, yes.
Thank you. Thank you for the interesting talk and great results. My question on graft rejection, how often do you see that, and how do you manage with steroids or removal? Thank you.
Yeah, thanks for that question. As I said, CARES, DALK, all these things. See, when you're doing a penetrating keratoplasty, we have to remember that we are also transplanting endothelium, which is highly antigenic. In CARES, you're not transplanting endothelium. You're not even transplanting epithelium, which is a second antigenic substance. You're transplanting only pure stroma. And with DALK, where we do a similar thing, where we transplant stroma plus epithelium, the rate of rejection is very low. And also in DALK, you're having such a large volume of tissue. The diameter is larger, the thickness is larger, everything is more. But even there, we stop steroids very early. We don't keep the patients on long-term steroids like we do in penetrating keratoplasty. So with CARES, where you're just putting a thin sliver of tissue, that too in the mid-periphery, away from the limbus, no sutures which could possibly loosen or cause inside vascularization or anything which can again increase the risk of rejection, and absolutely within the cornea. So if let's say if this is the cut section of the cornea, your CARES is somewhere here. So it is surrounded by normal host cornea on all sides. And the advantage of that is the host keratocytes repopulate this tissue very fast. Okay, so the donor keratocytes actually are repopulated by the host keratocytes. And all of these lead to a very low level of rejection. So the level of rejection is almost negligible. Now, between my series and Jack Parker's series, who's also a doctor in US, who's done a large number of cases, Jack had one case of rejection where the patient presented with some watering and some redness and things like that. For this patient, what he did was he just put the patient on steroids and it settled down very fast. So the normal steroid that we give for CARES is just for 1 month. Remember that. It's even less than a cataract surgery and at a low dose. So initial 2 weeks, it might go at 6 times and then we taper it down to 4, 3 and then stop it off by 1 month. Now, the worst situation, let's consider the worst possible situation. Let's say it has rejected. It really doesn't matter because what we are doing by CARES is we are just adding volume to change the shape. Whether the graph remains clear or not clear, it doesn't matter because the volume component is still going to be there. This would have been significant only in additional keratoplasty techniques which are covering the pupil. For example, a lenticule implantation. There, yes, you can get a drop in vision. But with CARES, it doesn't matter. It really doesn't matter.
Well, thank you very much, Susan. It was very interesting presentation. And I want to thank you for the very good job that you are doing. And first of all, my greetings to Professor Agarwal, because we already have many doctors from Armenia that pass a fellowship in your centers. And thanks for the training. This is very important part. And now it's time, because of the lack of time, it's time to go to Israel, from India to Israel. And with us, Professor Boris Kneiser, our good friend.
Well,
do you hear me, my friend?
Yep, I hear you. Do you hear me?
Yes, very well.
Well, firstly, I would ask some question, Dr. Jacob, Susan.
Thanks, Boris. It's very good to see you here.
Hi, how are you? Fine to see you. Ashraf, hi, how are you also?
Hey, Boris, how are you?
Hi, guys. Susan, so I have one question for you, if you can say me. What do you think about idea to perform firstly cross-linking to corneas, and after this to perform CARES? Maybe it can give you more stiff effect of this procedure.
Are you talking about cross-linking the patient's cornea and then implanting CARES, or cross-linking?
No. Perform cross-linking for the cornea for donation. Yeah, for donation.
Yeah, cross-linking the CARES tissue and then doing it. Yeah, so we did do that initially, but then we found that it's really extending the whole process, the time taken and things like that. And anyway, most of my cases are combined with cross-linking. I would say almost 95% of the cases we do combine with cross-linking. So if you're doing a CARES alone, it might have some effect. But when I combine with cross-linking, it gets cross-linked at the same time. So I really don't bother too much about it. I think it still gives quite good effect, because if you're getting 30 diopters of effect when you want to, then I mean, that is tremendous effect. And if you put more, you'll get more effect. So cross-linking may be an added advantage, but I haven't really pursued it fully as much as maybe it should be done. But I'm not so sure whether it'll make that much of difference either.
Good. And one more question: what your management after post-operative, after CARES? I mean, do you give some steroids for some months?
Yeah, just for 4 weeks. Initially 6 times a day, and then we taper it off over the next 2 weeks and stop it.
Okay. Good.
That's all, because the volume of tissue is too small to actually be very antigenic.
Good. Very interesting. Thank you. Great topic and great lecture. Thank you very much. Okay, so my topic. I try to share the screen. Do you see that or not? It's
not yet.
Not yet.
We see you very well, my friend.
Yeah, but
we didn't see you.
Okay, once again, we'll try it.
Artishaz, till Boris get ready, can I ask Susan one question?
Yes, sure.
Did you try in keratoconus to do a disc-shaped corneal graft like that, the same way with a central trifine on the pupil?
Yeah, so one of my cases was like that, if you remember, where the initial case which I showed, which was almost 360 degrees. So that is similar, except that I've not created a pocket to put it, but I've still put it through a channel.
This is what I mean. If you create a pocket smile and the whole graph, the whole lenticule, and you just refine it, I think it will manage in a lot of cases.
So that was actually a technique called Philly, which Dr. Sri Ganesh had done, where he was putting a smile lenticule and refining the central part and then inserting it. But one thing that you have to remember about it is that it's first of all, it's in a pocket. So it doesn't give you the amount of stretch that will come with just this thing. Second thing, there's a limit to how much of tissue you can implant with a smile lenticule, because how much will you get maximum? You may get 150 micron tissue if you're doing a 10 diopter smile. So that's another limitation. You'll not be able to get really thick lenticules.
Okay. I'm waiting to
Guys,
start.
I have some problem. If Professor Zelfian, if you have some
Yes,
other
yes,
lecture,
yes, we have one more lecture, and you hear me?
I will try once again.
If we will have time, during this
I
process,
don't know
we
what
have,
the
we have
problem
one
is.
more presentation, and Renato will be with us now from Brazil. He is very famous ophthalmologist again, as you all, and we are very happy to see this presentation. And after, Boris, I think you will be okay.
Yeah, hopefully it will work. I don't know what the problem is.
Yeah,
I
okay.
can share my screen.
That's fine.
I'll check that. Thanks.
Okay.
Can we put the sound? Artishas, can we put the sound of Renato of the video?
Yes, we are trying.
Hello, I am Renato Ambrosio from Rio de Janeiro, Brazil. I'm happy and grateful to participating in the second World Keratoconus Day from colleagues Ashraf Armenia and Artashis Zilfian, and I'm honored to collaborate with you. So the topic is multimodal diagnostics for keratoconus and ectatic corneal diseases, and this is a paradigm shift. It's important that I mention that I have some financial disclosures, including the brain, the Brazilian artificial network in artificial intelligence.
Ashraf, do you hear the presentation?
We have some softwares coming up commercially
Yes,
next year,
perfect.
and also a masterclass course that's coming to be international very soon. I also thank my supporters from the Vale June campaign here in Brazil, Medifacus, Genome, Oculus, and Opta Vision Health. All these collaborations are very important for us to support the Vale June campaign that we'll discuss a little bit in this talk. Ectatic corneal disease are not new. The first report from John Nottingham on the conic cornea, and I was very interested when I received this from Dr. Mark Manis from the University of California in Sacramento, and he sent me that the PDF of this original version. So there is a poem: only persistence leads to the goal, only abundance leads to the clarity, and the truth lives in the abyss. This is from von Stiller in the 18th century. It's a very interesting poem that resonates with what we do today for keratoconus. We want to learn more, and this learning experience has been evolving with the work of refractive surgery. We have, since the 80s, an exponential increase in number of publications, and this is related to the multimodal diagnostics. And exactly this topic was a review paper that was just published last week in Eye and Vision. So it's online, it's an open source, and I welcome you to take a look at this interesting review that we put together. We cannot talk about keratoconus without mentioning the work by Yaron Rabinovitz and Peter McDonald, the indices that they created for IS value and the symmetry between the eyes and the central K. And unfortunately, Yaron Rabinovitz passed away this week And we are very sorry to miss Dr. Rabinovitz, from whom we have learned tremendously. And we always will remember his contributions since topography up to genetics. Everything that we do in keratoconus diagnostics, Dr. Rabinovitz has some contribution, and he will be always remembered. It's interesting that we have these asymmetry patterns, the inferior steepening and the skew radial axis on topography. And this is important, that advances in corneal analysis from Steve Wilson, Steve Gleiss. I was very fortunate to do my fellowship with Steve Wilson. And I remember well when I was reading this first article, this was 1991, and that he has this finishing on the Helmholtz, Placido, and Gullstrand would be impressed with the technologies that topography will lead to the lasers so that we can reshape the cornea. When I did my fellowship, Steve Gleiss was keen to ask me why we should do refractive surgery with topography as a pre-op examination. And the reason is in this study that we found patients, half of the patients, about 1% of the patients that came as candidates have keratoconus, and half of these patients would have subclinical keratoconus, subsymptomatic keratoconus that only topography would lead to any diagnostic clues. So we need to go with the sensitivity of corneal topography, like in the right eye of this patient, but the left eye of this patient is clearly normal topography. And this is subtopographic is very important. So we need to go beyond, not over. And with this idea, we put together this editorial about 10 yeyears ago with Brad Gruneman, the editor of the Journal of Refractive Surgery, which is the journal that represents the International Society of Refractive Surgery that is coming to be independent starting next year. So I also welcome you to participate in the ISRS. So we have to go beyond, not over what? Detecting mild keratoconus. Detecting mild keratoconus with placido-disc topography. We have to go to multimodal refractive imaging to understand ectasia susceptibility, which is very important for us for the characterization of the enhanced screening for ectasia risk. It's important that we remember 25 years ago, Tel Sala described the first cases of ectasia, the first report with patients treated for high myopia with the LASIK, the impact from surgery, and also a few months later, the form-fused keratoconus case that was leading to iatrogenic ectasia. It's important that we recognize that those two cases, or two reports, in fact, allude perfectly to the pathophysiology of ectasia, the two-hit hypothesis, nicely described by McGee, and in which we have the corneal resistance and the impact from the environment. And of course, laser vision correction procedures weaken the cornea, but eye rubbing is the most common cause of ectasia. And any cornea may undergo the cycle of biomechanical decompensation, nicely described by Cynthia Roberts. It's important that we understand, though, if you want to avoid ectasia, start by telling patients not to rub the eye. And not rubbing the eye is one of the major concepts that we promote in our campaign, the Violet June Keratoconus Awareness Campaign. We know that misinformation makes the patient suffer even more than the disease. And it's very important that we educate the patients so that we can help them and also the families. But while we tell any patient in the world that eye rubbing is bad for them and also sleep over the eye, it's very, very important that we understand that aggravating keratoconus and causing ectasia is not the same thing. And it's important because of prognosis. So we have cases like this one that I always refer to. SBK LASIK, a thin flap LASIK in 2008, the PTA was 0.36, residuals from a red 304, so this is reasonable in terms of the impact from surgery. The patient had ectasia, and some people would say that little yellow here will be a pathognomonic for form-fused keratoconus. I have to say that this is kind of frustrating to have this discussion, but we started a very important study to look at the variability of subjective classifications. In this case, was case number 6. In these 25 cases that were sent with 11 colleagues, the mode was 0 with the first scale, the Steve Gleiss and Mike Smolik absolute 1.5 scale, and also it's a 0 to 4 with a 0.5 absolute scale, a normative scale. So this is a patient that has the pentacam pre-op and ectasia susceptibility with a D higher than 1.6, I would say 1.5, and the artmax lower than 400 would indicate ectasia susceptibility. So tomography is different than topography. And I start with some wisdom from Confucius. 25 centuries ago, he would say that the beginning of wisdom is to call things for the right names, by their right name. So it's important that we understand that multimodal corneal imaging, we have topography, tomography, shine fluid tomography, segmentation with the OCT and very high frequency ultrasound, biomechanics. And the same way we allude on corneal analysis, we also allude on biomechanics beyond corneal analysis, and also from wavefront in terms of understanding refraction. So it's refractive imaging. And that's not imaging because we have molecular biology and genetics. So I prefer to call this multimodal refractive diagnostics. So we can optimize planning of refractive surgery, evaluate complex cases, and eventually enhance safety and efficiency and efficacy. So when you think about that, we need artificial intelligence, which is applied with ancient intelligence. And we evolved to the cubic level. So it was A2I squared, now it's A2I cubic, in which we apply also artificial intuition, which is the continuous evolution for refractive surgery application of artificial intelligence. So we have the whys, the hows, and to go beyond. Interestingly, the first network for neural network, which is artificial intelligence for understanding topography, was developed by Steve Kleiss, along with his fellows at that time, Vipul Maeda and Mike Smolik. And interestingly, probably this is one of the first pioneers in ophthalmology and even in medicine. So we have to recognize that. And we evolved to what we do today with tomography, like the Bell and Ambrosio, and we go beyond with biomechanics. When we think about studies, we have to look at the data. And one case is anecdotally very interesting, but we have 105 cases with pre-op pentacam data that we have the bad D, compared to 3,278 stable LASIK cases. And we have a sensitivity of about 60%. We can improve with the pentacam random forest. That will be the base for the Bell and Ambrosio version 4 that is coming very soon. And this is a very nice work by Bernardo Lopes since his work in his PhD thesis on enhanced tomographic assessment for ectasia with artificial intelligence. But we need to go beyond. Even with the pentacam random forest, we have to go beyond. And the way to go beyond is with biomechanics. So we have the Corvus, which is a very ultra high speed shine from camera that takes in 31 milliseconds, 140 frames. So they can see the video, you have a keratoconic cornea and you have a normal cornea. So it's important that we understand this so that the cornea is more soft or more stiff in terms of how the deformation occurs. We combine tomography and biomechanics, and this is the seminal paper from 2017. So the Ambrosio, Roberts, and Vinciguerra report started with this study that included 94 cases with normal topography. And those cases would be very important because they are subtopographic, subclinical cases. So we have here like a substitute for biomechanical ectasia susceptibility. So the enhanced ectasia before surgery will also integrate residual stromal bed, relational tissue altered, and this is what we have in the brain. So if you are interested, you just scan this code and register in our website so that you can get the updates and register for the early software that will be free, available very soon. So we can use the score for relational tissue altered along with the TBI for improving the ability to see if the cornea can undergo LASIK, PRK, or eventually a therapeutic case. Maybe we have ICL and phakic IOLs, which is very important for us as a possibility for the weak corneas that cannot afford that treatment. So the relational tissue alter will be integrated with like the second hit for this type of understanding. So I have a case report for you. This patient is 13 years old. He presents with mild keratoconus in his left eye. The right eye is very normal. This is Ambrosio 2 scale on the keratograph 5. This is the Atlas scale, also in the keratograph 5. And this is going to be interesting so that we ask how advanced can help, advanced imaging can help. First, we can use advanced imaging in the right eye to detect mild keratoconus, subclinical keratoconus. And this is to confirm what I call Frou's disease. Interestingly, the fellow eye has a very weak cornea. The SPA1, the stiffness parameter at first applanation described by Cynthia Roberts, is very weak. And this patient, not only because he's 13 years old, I would say he has a very high susceptibility or even a prognosis for progression. And the progression can occur despite of the decrease in Kmax. That was exactly what happened. The Kmax, in fact, decreased, but if you see the most recent exam is a little more red here than here, which is beautifully seen on the subtraction map. The B minus C, you have this steepening, which correlates perfectly for the left eye, A, B, and C, with significance in the Bellin progression display. So it's important that we understand that ectasia can progress despite of Kmax. So you have to look at the maps, look at differential maps, and you can see much more important information. And this patient also reduced vision, so we have to treat this type of situation as soon as possible. Ectasia can occur only in one eye. Unilateral ectasia can occur. This is the left eye with very normal topometric map from Scheinfeld and topography from Placido. The incorrect vision is 20/20 plus. This right eye of this patient had a beautiful result with a mitochondrial ring assisted by femtosecond laser. He followed in London with Professor Reinstein that found everything normal in his left eye, along with the epithelial thickness and also the Damian-Gattinel score. So the interesting evaluation and retrospective analysis for 2014, we developed the TBI in 16 and published in 17, so it was 0, and in another follow-up, it came with a very stable cornea. So unilateral ectasia, not unilateral keratoconus. We also have segmental layer tomography, which includes high-frequency ultrasound and OCT. This work pioneered by Dan Bernstein, in which the thinning of the epithelium will be indicating a masking possibility for the cornea to smooth out the early ectasia. So thinning of epithelium would indicate ectasia. This was popularized by David Huang in his lab with Yang Li with the OCT. And we have the role of the epithelial thickness. And this is the fellow eye that followed in London. You see the OCT and with a thickening of the epithelium in the optical biopsy, as I call, and also the thickening that you can see on the maps. Very interesting situation. You have mild subclinical keratoconus and mild, moderate, and more advanced keratoconus, and you see the thinning on different eyes of different patients. It's important that we distinguish keratoconus and warpage. The thickening will be indicating against keratoconus and as the thinning. It's important that we get cases like this one. So this last case is a patient 19 years old, wavefront optimized refraction given 2015, relatively thin cornea, not very thin. And you can see the change on the scale, very symmetrical. With the same scale, Ambrosio 2 scale on the keratograph and on the topometric from Pentacam, you can see high correlation. The indices are also very normal. When you look at tomography, you have a little bit of change that you can see of abnormalities on the DED-D and the artmax, and this is ectasia susceptibility. If you look at tomography, though, you see thick epithelium, but it's important that you know this is the left eye. So there's a thick epithelium on artery view and also on the Tomei Tassia 2, and this is interesting. That will be against what we see on tomography and biomechanics. So the TBI is 0.96. The TBI optimized with artificial intelligence optimized was my AOS thesis, and it's interesting that we see this case, and the stiffness parameter is also very weak. However, what happens? What is the truth? The truth is that this patient has in the fellow eye, in the right eye, advanced keratoconus. So you see the advanced keratoconus in the right eye and the mild keratoconus in the left eye, subclinical keratoconus. So this thick epithelium does not go against the Reinstein law of epithelial modulation. You have a thickening here, but the thin epithelium is coincident to the thin part of the cornea. Also, the fellow eye, you have a thick epithelium in the area that you had loss of tissue because of the severe ectasia. So advanced keratoconus and formed fruits keratoconus, and the saying the maps is very important. That's one of the possibilities that we can use artificial intelligence in our favor. Another thing is genetics. We have potential for a new revolution diagnostics to identify some genes, not only genes for collagen, but also genes for the ectasia susceptibility as the second hit for inflammation and for eye rubbing and allergy. Ectasia susceptibility is very important, and we have this case published, and we got this identical twin sister that had in the left eye, in the second sister, both eyes with a normal topography, and the TBI is abnormal in both eyes, and you have some abnormality on the AVID gene from Avellino, which is very interesting and is something that we have to look at in detail for prospective and retrospective studies. Nice work by Bangalore with the LOX oxidase, lead by Professor Hoynshetty, and this is going to be very important for us to understand ectasia susceptibility, which is different than when we manage patients prior to keratoplasty, in this paradigm shift that we had for keratoconus treatments with corneal rings and cross-linking. So we have to be objective. We have to understand and how to apply artificial intelligence to understand that screening, diagnosing, staging, prognosing, classifying, and clinical follow-up for progression are different aspects of multimodal corneal refractive diagnostics. So this is an honor to participate and to talk to you about this true imaging revolution in evolution. And I thank you for your kind attention, and happy Keratoconus Day to all of you. And thank you very much for your support. Join the volunteer team. Let's work together to promote keratoconus awareness and to improve the ability for us to help.
Okay. Thank you very much. And then, it was a very interesting presentation, and we are very happy to hear this kind of presentation. Again, connected with AI. It's very popular theme, I think. And now, if Kaiser with us, we can hear him. If not, hi, Kaiser.
Hi. Now
Okay.
I'm fine.
We see your presentation now very well, my friend.
Yeah,
We-
good. So
if you are ready, if not, we can do one more.
Yeah, I'm fine. Now I can share my screen, so
Wonderful. Okay,
get started.
so we hear you very well.
Do you hear me good? Yes.
Yes, everything is fine.
So firstly, good morning, and thank you for your invitation to give this topic. I will go to speak about thin corneas. I mean the cornea that less of 400 microns. And my topic was corneal cross-linking with riboflavin and UVA in keratoconus patient and thin cornea. So I'm from Israel, as you present me before. Okay, I don't have any financial interest for this presentation. So some facts. The first one that I wanted to tell your audience, like 10-20% of keratoconus patients require some surgical intervention for keratoplasty, for treatment of keratoconus. I mean, or DLK or DALK or penetrative keratoplasty. And like from other work we know of Daniel Goodfroich in 2016 that he published in Acta Ophthalmology, that after that we start to use cross-linking in treatment of keratoconus, 25% was reduced after the using of cross-linking. So we start to less operate our patients. And the reason of that, as I said before, it's cross-linking that was performed and was developed by Theo Seiler in 2003 or 2002. What I want to say here is that cross-linking is an important treatment of our keratoconus patients. But the question that I ask myself, or maybe you also see in your practice, what the amount of the patient have thin corneas, because we know very well that I can't treat our keratoconus patients with thin corneas, or we can treat, but we need to modify some or to change some protocols and give the treatments by cross-linking. So we can't leave our patients with thin corneas without any treatment. So of course, for visual acuity, you can give contact lenses or rigid contact lenses or another one, but actually to help keratoconus, to finish the progression of this disorder, we need to perform cross-linking. So how we can work with that, or how we can do that? In these small studies that I curated in my department, I check what populations that I need to treat. So I live in the southern part of Israel. It's a very unique area because we have not only Jewish population but also Bedouin population. Bedouin population, it's like Arabic. It's Arabic population actually, but they have not settled in some places, and they have Bedouin or rural tradition life. So in my department, like just 200 patients, 200 eyes, and check what the thickness of corneas that we need to treat. So you can see here that like in Jewish populations, like 40% of these patients, and in Bedouin populations, 50% of them have thin corneas. But what I mean that I need to do something for these patients to help them, but I need to change because, as you know, from other studies, for example, Sporel and Theo Seiler in 2007 published a study in the cornea that then show the toxicity of cross-linking. So we know that if you treat thin corneas less than 400 microns after the debridement, you can damage or create some toxicity to endothelium. And if you will do that, actually the results of that, it's corneal edema, and you can damage to create corneal edema and haze, and of course to damage the corneas. So what we need to perform, what we need what we can do. Here I can present some nomograms, not nomograms, some graphics or some possibility to treat thin cornea. The first one, we know the first modification of Dresden Protocol was created in 2008 by Farhad Hafez. Was published in Journal of Cataract and Refractive Surgery journal, and he developed hyposmolaric riboflavin. The idea of that hyposmolaric riboflavin just to swell the cornea. If you have cornea after the deepitalization like 350, like 360 microns, you need to swell this. You can swell this cornea by hyposmolaric riboflavin, and after that you get 400 microns, you can start the treatment. But this, as I understand, some of methods have some cons and pros. So the big disadvantage of this treatment that you need, firstly, you need to prolong your time for the treatment. First, you need to install the riboflavin. After that, you need to also to swollen the cornea to get 400 microns of cornea, and after that, you can start the treatment. So the period of your treatment are going to be more prolonged. So what another options do you have to treat this disorder? One of them is epi-on cross-linking, but a disadvantage of epi-on cross-linking, as you know, the effectiveness of this treatment will be less due to reason that oxygen is that's embedded in the cornea less than an epi-off procedure. So epi-on procedure, good one, but not still enough to get good stabilization effect like epi-off procedure of cross-linking procedure. Another one procedure that was planned to invite or developed is by Cosimo Mazzotta, and he published it in Clinical Ophthalmology 2014. It's epithelial islands cross-link technique. What do you mean? You leave the epithelium on the thin part of the cornea or the minimal corneal thickness area, and you can remove around that and start to put drops of riboflavin. It's going to cornea from the side, going in vertical, and also horizontal inhibition of riboflavin of the cornea, and after that you can start cross-linking. So it's also not so maybe so precise technique, and all the time the doctors look for another technique. So Susan Jacobs that gave a representation about CARES create another one technique. It's 2014. She also published that. It's contact lens assistant cross-linking, and I will speak about this a little bit later, because this is technique that I find in my practice as good one. And the last development that you know was created by Farhad Hafez in 2020, and Rohit Shetty, creation of new nomograms for thin corneas. So now I can start to speak a little bit about techniques that I start to use in 2015 for my patients with thin corneas. I mean corneas less of 400 microns. We got the idea of Susan Jacobs of contact lens assisted crossing, but we not using standard protocol, not in the resonant protocol, not in, I mean the irradiation not of 30 minutes. We start to use accelerated cross-linking, 9 milliwatts for 10 minutes, and check our results. So after 2-3 years of using, we retrospectively review this group and check the safety and efficacy of this treatment. So I speak about contact lens assisted cross-linking, but with accelerated protocol. And we find this work we published in Journal of Refractive Surgery in 2019, and found that accelerated CX6 contact lens assistance cross-linking led to stabilization in 80% of corneas, and it also didn't find any side effects or adverse effects of this treatment. So after these results and after this starting working with this treatment, we start to think where we can go, and actually planned one more study to compare two groups. Group one that treated by accelerated cross-linking, but it was corneas with about 400 microns, and the second group that was treated by cross-linking, also accelerated cross-linking with contact lens, but less of 400 microns. Okay, so just here I want to present our results and to show what was the stabilization rate and the efficacy of this treatment compared to only accelerated cross-linking in corneas about 400 microns. So this is my protocol that you can see after the pachymetry, and you find after the depithelialization. Actually, firstly you depithelize the cornea and check the pachymetry. If you find less of 400 microns, as I say, I'm not going to perform standard to accelerated cross-linking. I need have some method to or swollen or to get cornea to be more thicker. So we start to use contact lens. The first contact lens need to be not hydrophilic, with good percentage of oxygen inhibition in the cornea. I mean the penetration of the lens, and also it's need to be with good UVA barrier free. So as you understand, if your contact lens absorb UVA, you don't the cornea will not get enough enough amount of UVA. So I need to be sure that my contact lens that I prefer for the using for this treatment need to be UVA free barrier. So after that we put cross-linking for usually for 20 minutes. Usually we use you can use isosmolaric. You don't need to use hyposmolaric riboflavin. And parallel to that, contact lens we put into riboflavin solution. After that, just cover cornea of patient's cornea, you cover with contact lens, and after that you can irradiate the patients. You can see protocol of our irradiation. It's 9 milliwatt per centimeter square with power. Actually, the final fluence is 5.4 joule per centimeter square. We're using cross-linking lamp of LightLink. It's LightMet manufacturer, but it doesn't matter what lamp do you use. Actually, you need just to get this intensity and fluency. Here I just want to show it's my cornea that you see my normal cornea of 548 microns, but I just put this lens that I use in my practice. We working with a pure vision of Bausch & Lomb contact lens. So I say it's hydrophilic contact lens and UVA barrier free. And it's after that I put contact lens on my eye, you can see the thickness. It's going to be more like 660 microns. It's 110 microns more than was before. So it just to show that is how it's technique working in some objective method of measurement of our corneas. So, for example, if you have patients with 350 microns, it will be finally you will get 450, 460 microns of thickness patient cornea. So what was our results? I will will present you all demographic data. It's not so interesting, but our results of visual and keratometric results. So you can see, actually, if you compare two groups, one of was control group, it's a group about 400 microns after depitalization, and the second one less of 400 microns. It was control group. You can see in both group was improving in the visual acuity, the final visual acuity after 1 year of follow-up. It was improved in both groups. Actually, this table that I want to present you, UCVA and BCVA was better after one year follow-up in both groups, but other data like maximal keratometry or K-mean and anterior astigmatism, it was same. EDC in the endothelial counts, in the endothelial density counts was also significantly changed and was less after the treatment, but it was same between two groups. It was not subabnormally compared to the age or for the treatment. So our stabilization rate was in ACXL group was 84%, in ACXL accelerated contact lens assistant group was 77%. So it's like 8% of difference, but it was not statistically significant. What we can actually the safety of the both treatments was same. So we didn't find any ACE or corneal sterile infiltrates or some corneal other pathologies during the follow-up. Okay, and as I said before, the counting of endothelium was same, and they're using same rate between two groups. So for conclusion, I can conclude that actually we performed the first studies that compared to groups between accelerated cross-linking and accelerated cross-linking with contact lens, and we find that both groups provide stabilization effects similar and without any significant changes between two groups. So if you have, it's one of your that actually we show that contact lens assisted accelerated cross-linking can work, and you can use it in your practice. But the follow-up was only 1 year. So now we actually do the work of follow-up of 3 years, and hopefully in next summit we'll present our data, and I will share with you what will be our data finally after 3 year follow-up. But of course, as I say, each method has some cons, some pros, some advantages, and some disadvantages. So the big disadvantage of this technique of contact lens, you swollen or you enlarge the thickness of the cornea by 100 microns. Yeah, it's artificial enlargement. But as you know, the important part of cross-linking for keratoconus patients is anterior part of this disorder. So actually, if I enlarge or I increase the corneal thickness, artificial increase in corneal thickness, they reduce the important part of cornea that can get the cross-linking. It will be less that in normal or epi-off procedure. I try to say that actually logically by contact lens assisted cross-linking you will get less stability that by the standard epi-off or accelerated epi-off procedure. Okay, so Farhad Hafezi, I think also Susan Jacob was included in this study. Then check in laboratory results if contact lens assisted cross-linking give same stabilization effect as you saw, as I show you. We got almost approximately same clinical effect after 1 year. But then check in laboratory studies and check on the New Zealand rabbits, and Farhad Hafezi showed that contact lens assisted cross-linking reduced stabilization effect by 30%. So in laboratory studies, it's something one, in clinical studies, something other. But as I say, after 3 year follow-up, we continue our study. So after 3 year follow-up, I will say maybe more precise replies for this question that I ask myself. If it's still stabilization effect of cross linking with contact lens assisted, same like usual epi-off method. So as I said before, we have also nomograms. It's very interesting and very exciting development for me, because here it's more easier to treat. It's more easier to treat your patients. You not to start to think what kind of riboflavin you need to use. You don't need to use to get some more stuff, stuff like iontophoresis or another one for inhibition of riboflavin. Here you have nomograms that was planned. It was developed by mathematical developments, and you can choose what kind of riboflavin you use and what kind of cross-linking you use. For example, here you see I use 9 milliwatt per centimeter and square. It's my preferable protocol, and this is in the orange line. So if after the debridement I got 320 microns, I need to use, for example, like 7 and 30 minutes. So you just do vertical and horizontal line, and you got the time how you need to treat your patient. Okay, so if you have some machine that treat 9 milliwatt for 10 minutes, so you can finish before like 7 minutes and 30 seconds, and you finish the treatment. This is nomograms of Roy Chetty that published in JRS in 2020, and another nomograms also very popular that was published in 2021 by Farhad Hafezi in AJO, American Journal of Ophthalmology. that actually the idea of this development of this method, you just remove the epithelium, you give to your patients 20 minutes of riboflavin soaking, check pachymetry, you got some pachymetry of your patient, and after that you check how much minutes you need to treat your patients. Okay, it's very easier. He calls it sub 400 protocol. Now he create another version 2 for 9 milliwatt accelerated cross-linking, because this table that you see here, it was developed for standard protocol for 30 minutes or 3 milliwatts per centimeter and square. And in the future, or I think it's soon, he will publish the new version for 9 milliwatt. So actually, what I use now in my practice, in my department, we're working in Israel. Some of our doctors still using, because we find this nice technique and very easy technique, accelerated contact lens assistant cross-linking. But I am with my patients more and more use nomograms. And actually, I will say you some small secret. I try to compare 2 nomograms between Hafez's group and the Rui Chetty group, and we'll check what the efficacy and safety, which one is better. Maybe will be same. I think it will be same. But anyway, we need some evidence based to take solution, to take some decision what the method is better for us, and use it in our practice. Okay, thank you very much. Hopefully you'll find it's interesting topic for you.
Thank you, Boris. It was very, very interesting presentation about cross-linking. I'm sure we will have many questions and answers at the time for that. It will be at 2 o'clock. And now, thank you, Boris. And now we are going to Georgia, to our good friend, Merab. How are you? Do you hear me, my friend?
Hello, dear
Hello.
colleagues.
We hear you.
Good afternoon.
Yes,
Good
we hear
afternoon.
you.
I'm very glad to see the very well-known faces for all the world, and for me too. Thanks to our colleagues from Armenia for they organized very good event today. It's very interesting, and I think our young colleagues and all over the world will watch this symposium, and they find a lot of interesting new things. Okay, so this is as well as know, keratoconus clinically presents with a irregular astigmatism, high order aberrations, so-called coma, and with visual impairment with a reduced quality of the life. Various treatments have been developed to halt the progression of the disease and improve the visual acuity, but the management still remains challenging. Some keratoconus patients need more than one treatment during their lives. The goal of the treatment on the stage of the disease, at the early stage of keratoconus, to halt the progression of the disease, we use a corneal cross-linking. It's usually method for today, and sometimes we in our clinics use also intrastromal corneal ring segments implantation as stop the progression of the keratoconus too. At the late stage of keratoconus, today we have very good procedure, DIALC, and PK is a well-known procedure also. So in our clinic, we have been performed cross-linking since 2007 using an epithelium off technique for ensure deep penetration of the riboflavin into the stroma. Many modifications have been developed over time, again, aiming to optimize its duration and phases to order the improve the safety and efficacy of procedure. To reduce the procedure time and ocular discomfort, we have been used today accelerated corneal cross-linking with from the 2016. Both standards and standard and accelerated corneal cross-linking today we use in our clinic, both of them, and they are both safe and effective. However, with the accelerated technique, the cornea is exposed to ultraviolet riboflavin for shorter period of time, 10 minutes only. It's very convenient. In case of thin corneas, when the pachymetry of the thinnest zone is around 400 microns, we perform corneal cross-linking with hypotonic riboflavin. Next. Another method to halt the progression of keratoconus, as I told, is intrastromal corneal ring segment implantation. You know that this is very small device made of the synthetic material PMMA, which are implanted within the cornea stromal, creating an artificial limbus. As I decide, you see at the picture, it looks like a limbus, and so it's changed the curvature of the cornea and geometric and the refractive power of the cornea. The aim of intrastromal corneal segment implantation is orthopedic function. So, okay, thank you. Yes, thank you. Yes, and so till we have the rings in the cornea, it works. If we remove it, okay, again the cornea get the previous curvature, and so we should make the good surgery to have the rings in the cornea during the lot of time. In 1998, Professor Joseph Collin published a report in Ocular Surgery News where he presented his first results using the large diameter rings in patients with keratoconus in an early stage. But the idea to use the intracorneal ring segment idea came from the work of Baraker, Professor Baraker, Spain, and Blavatsky, by the way, from Armenia. She was a professor in Armenia many years ago, and now when we use the different types of ring segments, I mean the thickness, length, and other parameters, there is a idea which gave us the Blavatsky in her experimental works. For today, there are different types of intrastromal corneal ring segment on market, and among them, I would like to tell about the three models: Intacs, Ferrara Kera rings, and my Kerabo. This we used at the beginning Intacs, then for today we use Ferrara rings and our Kerabos. Rings act as special elements between the collagen fibers of the corneal tissue, induce arc shortening effect, thus flattening its central area. Customized refractive effect can be achieved based on the different parameters of implants. The quantity, for example, they can be 1 or 2 segments, arc length, thickness, inner diameter, and the width of it. Next slide, please. There are three main differences that distinguish Kerabo from the other corneal ring segments. Unlike triangular and hexagonal shapes of cross-section of Kera ring and intacs, Kerabo has beam shape with a smooth edge, and this is, we think, more friendly for the corneal tissues due to different numbers of fenestration in the corpus of the Kerabo segments. In our opinion, again, we think the nutrition process of the cornea is improved. As the time for the nutrition comes from the behind to the upper chest of upper part of the cornea through these holes. At the time of creation of Kerabo, we consider that the optimal size of the inner diameter should be 6 millimeters. The inner diameter of the Kera ring was 5, and in these cases, we have the complaints from the patient about the hair halos and glares in the condition of low light. The intacs with the diameter was at the beginning 7 or 8 millimeters, causes corneal neovascularization and low effect of refraction. Finally, macula manufactures the Kera ring, and the intacs approach the inner diameter of the segment to 6 millimeters. And they say that it's also best selling the model of their models. The number of thickness, position, and arc lengths of the segment are determined based on the manufacturer's nomograms. Signs are chosen from the nomogram, taking into account the refractive error and the topographic map of the disease. So we have here the 3 types of nomograms which are used based on the type of corneal asymmetry. In vast majority, the clinical cases who receive good results with intracorneal rings implantations. The nomograms we consider to have some limitation, as most of them are based on the clinical data and variables that we very subjective in patients with the keratoconus. Some authors and me partly agree that if the surgeon isn't sure about the quantity and the size of the intrastromal corneal ring segments, it's better to implant one segment and make the just intrastromal tunnel for the second one in order to later decide for the refractive effect of implant or no the segment, and if yes, what should be the parameter of segment. It's easier much. We have been using intrastromal corneal segment since 2003, and there are several of many images from our clinical practice. As you can see, segments with the different parameters were chosen to achieve best possible refractive effect in this case. There are some more images of our patients, and I wanted to outline that during the 20 years of our experience with the rings, we have used almost all types of them except Mayo ring. For the achievement of the significant refractive effect, accurate and customized calculation of the different parameters are crucially important. This slide demonstrates the case report of our 29-year-old patient who underwent Kerabo one segment implantation on his both eyes, and we received uncorrected visual acuity of 20/20. Of course, this patient has regular checkup and achieved refractive results are stable for almost 5 years. As we have already mentioned, a lot of keratoconus patients need more than one treatment throughout their lives. The main aim of is stop the progression of the disease forever, as keratoconus affects the adolescents in their most productive years. Social and economical burden from visual impairment represents a serious concern. We have an individual approach in each clinical case. Following cross-linking, when the stabilization of the disease is achieved, we consider effective ACL implantation for the visual acuity improvement. If the clinical parameters for example, anterior chamber depths, contraindicated ICL implantation, scleral contact lens are the good choice. Intrastromal corneal ring segment implantation not only improves the refractive parameters, but also stops the progression of the disease. However, in some cases where full optical correction is required, we consider ICL implantation, scleral contact lens, or phaco with a toric IO in combination with intrastromal corneal ring segment. You can see the slide. If the signs of the disease progression are still present following intrastromal ring segment implantation, we perform cross-linking in cases of form fruus keratoconus. We perform LASIK for the refractive correction, and after 5-6 months, cross-linking. But this patient should be, during this period, should be under our control. Intrastromal corneal ICL implantation in case of keratoconus is often performed in conjunction with other treatment procedure. For example, as I told, cross-linking or intrastromal ring segment implantation. The combination of these techniques is typically used to correct high levels of the refractive errors in patients intolerant to contact lenses. We have been used the so-called visco-free ICL implantation technique since 2015. In this technique, the depth of anterior chamber during the implantation is maintained with a continuous irrigation with a balanced salt solution through the 220 gauge maintaining cannula. So without any visco, using the BSS instead of OVD during the implantation results in the prevention of accumulation of residual OVD material between ICL and the natural lens. This image demonstrates the first day after ICL implantation. The posterior, the patient underwent ICL cross-linking several months before the surgery. You can appreciate the clear cornea with ICL in place and the whole thing within normal range. After cross-linking, we usually wait for 5-6 months to achieve the stable refractive result, being based on which we calculated the ICL. In rare cases where the signs of disease progression are still present following intrastromal corneal ring segment implantation, we consider cross-linking. In cases when there are no sign of disease progression following strong intrastromal ring segment implantation, but the full refractive correction is not achieved, we consider also ICL implantation. This slide demonstrates clinical case of our 22 years old patient who underwent rings implantation, and the base corrected visual acuity was 20 to 40 was achieved. However, the patient required visual acuity 20/20 due to his professional demands, and he could not wear contact lenses. Toric ICL was calculated with detailed precision and visual acuity of 20/20 in achieved followed ICL implantation. Yes. Custom designed scleral lenses are considered one of the best choice for refractive correction in patients with after cross-linking and or after intrastromal ring segment implantation. Scleral lenses walk over the cornea and rest on the sclera. There is a reservation of pure saline solution between the back surface of the lens and the front of the cornea. This ensures that the eye is always in liquid environment. Patients with the scleral lenses usually report improvements in visual acuity and comfort. As we have mentioned, we started intrastromal ring segment implantation in 2003, and some of our first patients have already reached the age of 40, and they developed cataracts. In cases with this, in case like this, phacomuscular with toric IO implantation is considered the best choice as we are able not to remove the cataract, but to consider any refractive error if present. In cases of form-fruits keratoconus, we consider performing LASIK for the correction of the refractive error, and as I told, after 5-6 months, cross-linking to maintain the achieved results. There are some complex cases when desired results can be achieved even with 2 procedures. This is a case of our patient who underwent penetrated keratoplasty for the end stage of the disease. Later, we implanted intrastromal corneal ring segment to stop the progression of the new cornea and transplanted cornea, and as a final step, cataract phacomusculation with a toric EOL implantation. So to sum, our corneal cross-linking is a safe and effective procedure to halt the progression of disease. Even though not all the researchers share the option. Our 20 years experience shows that properly implanted segments, especially 2, can stop the progression of the disease in most cases. We have examples from our clinical practice proving that intrastromal corneal ring segment can stop the progression of keratoconus. Some patients who underwent the implantation of rings in one eye because of clinical significant keratoconus, and the other eyes will with a subclinical keratoconus was left untreated. After 5-6 years on the follow-up visit, we found that the data of the eye with intrastromal ring segments were stable, while the data of the untreated eye showed the progression of the disease. Combined procedures with ICL implantation to correct the refractive error are safe, predictable, and effective option to improve the vision acuity and the quality of life keratoconus patients. Thank you for your attention, and you are very welcome to visit our meeting, which we have on December 16, 17 this year. You are very welcome. Thank you very much.
Thank you, Merab, very much. It was very interesting presentation as a rule. And of course, we will be here. We will be with you in Tbilisi. I think Armenian ophthalmologists know this event. Thank you very much.
Thank you, Zulfid. Professor Zulfid, and very good conference you organized. Thank you.
Now, my friends, I think you hear me very well. And we are continuing our conference. Now we are going to Armenian speakers, but again in English. And in the end of the session, we will have answers and questions and answers. Okay. Do you see my presentation, Ashraf? Do you see my presentation now?
Not yet.
Not yet?
Not yet.
Okay. Let me know when we'll be okay.
Okay. Hi, Professor Devali. How are you?
Hi.
So we will have no time to miss each other. I think in 1 month we'll meet each other.
Exactly,
Yes.
exactly. I'm going to see you
Yes.
soon.
Thank you. Very
I
welcome.
think we will meet in Georgia, Merab. Yeah?
Yes.
With Ashraf as well.
But I think in Oman too, yes?
In Oman too.
Armenia.
Exactly. Yes.
Maybe. Who
In
knows?
the Miyako. The Miyako,
It
yes.
will. So
Um,
okay. Okay. Very good.
Okay. Now, do you see my presentation now?
Yes, yes.
Yes,
Everything
very
okay.
clear.
Okay. And my report will be more scientific, not so clinical as yours. And I will introduce just a few words about our new journal. It will be published very soon, and the first Armenian medical ophthalmological journal, the Eye Health Journal. And we will show you. Many people already sent the articles, and all of them will published. So my team is about implementation of a new method in diagnosis of keratoconus. As we all know, keratoconus is a degenerative non-inflammatory disease of the cornea with progressive corneal stipping and thinning, most typically inferior to the center of the cornea. Keratoconus is characterized by progressive myopia, both regular and irregular astigmatism in mild cases, and vision compromising ectasia in advanced disease. It is usually bilateral and asymmetrical. The incidence of keratoconus is 1 in 2,000 of cases. It's approximately. Often compliance blurred vision, glare, light sensitivity, and history of frequent change of glasses. Etiology, genetic factors, less than 1 in 10 that blood relative of keratoconic patients will have keratoconus. Eye rubbing among keratoconic patients has been reported in 73% of cases. Hormonal changes often developed at puberty or advanced in pregnancy. There are systemic and ocular associations with keratoconus diseases that are associated. Systemic associations is Down syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, mitral valve prolapse. From ocular associations is retinitis pigmentosa, Leber's congenital amaurosis, microcornea, aniridia, corneal degeneration, different types of congenital cataract, ectopia lentis, lenticonus, macular coloboma, retinitis dysplasia, retinal dysplasia, and floppy eyelid syndrome. Pathogenesis remains unclear. There are several factors leading to keratoconus development. Genetic factors, corneal stromal degenerations, and inflammatory factors increase cytokines level, interleukin-6, tumor necrosis factor, and MMP9. Recently, many researchers provide the important role of inflammatory factors that I mentioned before. What is matrix metalloproteinase? Matrix metalloproteinase, MMP9, also known as gelatinase, involved in the degradation of extracellular matrix. The main component of the cement membrane, we know that is 4-type collagen. MMP9 is responsible for degradation and degeneration of collagen for this type of 4-type collagen. Respectively, MMP9 could have a key role in the development of keratoconus. Here you see how looks the human cornea, the healthy collagen. And here in the 3rd and 4th stages of keratoconus, we see what's happening in the collagen of keratoconic patients. The aim of this study, we have 2 phases. In first phase, detect increased MMP9 level in patients with keratoconus compared to control group. And in second phase, determine level of MMP9 in tear and its associations with stages of keratoconus. In first phase, we have 120 patients. In group 1, we have first to third stage of keratoconus, 60 patients, 60 eyes. In group 2, we have control group, healthy population, again, 60 patients, 60 eyes. In second phase, 150 patients. In group 1, for first to third stage of keratoconus, 75 patients, 75 eyes. And in group 2, control group, healthy population, 75 patients, 75 eyes. Which are inclusion criteria for this study? In first group, anterior curvature more or equal to 46, back elevation more than 20, pachymetry less than 430 microns. In group 2, it's control group, anterior curvature less or equal 46 diopters, back elevation less than 10, pachymetry more or equal 520 microns. Double-blind study of elevated MMP9 was done in tiers of patients with keratoconus, first to third stages, and in healthy population. Procedure was done in the examination room office with a collection of tear with special mini pipette. The detection of MMP9 was done with ELISA analysis. Take a look, these 2 lines is positive and 1 line is negative. It's just examination. And with ELISA, we calculate the level of increasing MMP9. How we collect tear is very easy. It's just, I just tell you about it. It's just in the room office, very easy. With mini pipette, we take this tear film. In results, MMP9 in first phase was detected in 58 patients out of 60. In second, average level of MMP9 was 40. 40 and more, we know that this is disease and we should be very careful and pay attention for this. Here you see our results again. So in conclusion, this study showed that the key role of MMP9 in development of keratoconus is already done. The first phase of this study proved that MMP9 is elevated in tear of patients with keratoconus. In second phase of this study showed significant elevation of MMP9 level in tear of patients with keratoconus compared to control group. Moreover, second phase showed the correlation of elevated MMP9 level between the stages of keratoconus. So in third stage, we have very high degrees. Conclusion: detection of elevated MMP9 could be an additional tool for diagnosis and management of keratoconus, especially in patients with subclinical keratoconus. Our results were shown in international conferences in London, ESCRS, Lisbon, again, ESCRS, Moscow, Milan, and published in international journals. This method was patented by me as a Zilfian keratoconus test. We are going to present this method, the new findings and studies. We are going to show these results in instructional courses in ACRS and ESCRS in 2024. So you are welcome, my friends. And of course, our vision will be the next research topic to invest a new method of correction, elevated MMP9 level, which can be the new treatment of keratoconus. So thank you for your attention.
Amazing presentation, Artash, as usual. Do you hear me?
Yes, my friend, thank you very much. I need time to sit. Okay.
Yes, and in my opinion, you should collaborate with Rohit Shetty for this MMP9, because you know that Rohit and Bourgeois are doing a lot about the tear film biomarkers nowadays since 2 or 3 days. So maybe we can invite one of them to the courses in the ASCRS with the ISCRS. It will be a nice collaboration.
It's a good idea, my friend. Yes, I agree. For sure.
Yes.
Thanks.
And I have one question because
Sure.
yes, for the ICR that you develop with the holes in the rings, did you measure the high order abrasion of the patient during night? Because you know that every circle in the ring, it will develop a lot of high order abrasion at night during the pupil dilatation. And in spite of a solid ring, the solid ring will decrease less abrasion than the holes in the ICR.
Merhaba.
Did you hear me, Diwali?
Here we have a question from Ashraf. It was about, do you calculate the hole size or something?
The higher order
aberrations in your rings, or the size?
Sure.
Yeah.
We have a barometer and we do it, but it was a reason why we decided that 6 millimeter distance between the rings, these two rings, is optimal, because yes, some of them, especially the drivers, young drivers, they have these problems in the beginning. After some months, sometimes after a year, they decrease. But anyways, we tell them before the surgery that it can be, but we cannot say what level it will be. It's a very different, subjectively and different. In some patients, after some months, as I told, they did not notice it, and some of them still some years they need to be relative to this aberrometry problems. We had 1 or 2 cases when we removed the rings, and as I remember, we put them, make the cross-linking, and then we it was the reason aberrations, high-level aberrations, and then we make make the ICL, phakic lens implantation. 1 or 2 cases it was, not more. So, but when we used is the beginning, when we use the Ferrara Kera rings, which have the 5 or 5.5 millimeter of there was much more cases with the these high-level aberrations.
There's a highlight because Boris left. Boris said that he's using for the sub 400 contact lens the technique from Susan Jacob. But I think that me and Cosimo in 2021 we published a long-term results of the accelerated 9 milliwatt corneal cross-linking for the early progressive keratoconus, and we develop different ways of for sub 400 according to the power setting and how the depths needed for the sub 400 without the using of contact lens anymore. So just because Boris left, I wanted to highlight this.
Boris.
But he told me
Okay.
that he will be with us very soon again.
Oh.
We will take.
Boris.
This one. Well, it is for Boris you told, but we also remember your notice.
Yeah, because nowadays we rarely use the contact lenses for the sub 400. You can change on the machine the power intensity and the time of duration during the cross-linking, and this will take you to a different level of depth on the stroma, and you can have a deep demarcation line without the using of contact lens nowadays anymore in sub 400.
Okay.
Okay, thank you very much. Thank you very much.
Very good.
And now, dear colleagues, we should continue. And the next presentation will be done by Dr.
I will say I should leave Artishaz, and
Okay.
thank you so much for this wonderful day, and I think you are going to continue more and more for wonderful topics. Thanks.
Thank you, Ashraf. Thank you for being with us. Thank you, my friend.
Congratulations, Artishaz, for this amazing Congress. Congratulations.
Thank you. Thank you. Thank you, Merab. Thank you, Ashraf. Thank you very much. See you soon.
Thank you. See you soon.
Thank you, my friend.
Good luck.
Good luck. And now we are going to next presentation, Dr. Davtsan. She is Vice President of Armenian Keratoconus Society, and she will present, her topic is about complications of cross-linking. You are welcome.
So if no one on Zoom platform, may I talk in English or in Armenian, as you think? You should, okay. So first of all, I would like to apologize for this confusion in program, and I will be short as I can. Now my presentation is on complications after cross-linking, the clinical cases that we came over during our practice. I do not want to stop what is keratoconus, how we can treat it, because we have a lot of presentation on this topic, and I jumped directly to mine. And what we can see after cross-linking: delayed epithelial healing, infectious keratitis, non-infectious keratitis, corneal opacification, reduced visual acuity, blurred vision, and endothelial damage. Usually we talk about delayed epithelialization when we have persisted epithelial defect after 10 days of cross-linking. Usually complete epithelial healing is observed 3 days later after the procedure, and we kept contact lenses for 3 to 5 days. The first case, unusual delayed epithelial healing. The patient underwent accelerated cross-linking, and 1 week later was seen with unusual epi defect, like dendritiform epithelial defect. The first impression was epithelial defect due to herpetic disease, but it is not classical dendrite from herpetic disease, and we just reduced steroids, dexamethasone drops to twice a day, and added and added fluorometallone as a MMP inhibitor. After 10 days, dendritiform superficial opacification was seen, but epithelium was closed, and after 1 month, this irregularity goes away under the steroid treatment. Sterile keratitis, usually considered to be a short-term complication. They occur peripherally, do not impair the vision, and responds very well to topical steroid. Risk factors are contact lens-induced hypoxia, alcohol use reaction to UV, overdose to UV, and topical NSAID drops. The second case, 23 years old female with keratoconus stage 2, accelerated cross-linking was performed 3 days after treatment. Peripheral corneal infiltrates were seen, and they are not considered as infections because we don't have anterior chamber reaction and stromal edema, and also the culture was negative. Here you can see those infiltrate in periphery. Some of them are already resolved under steroid treatment, and the big one is still there. The third case, young 90 years old female, keratoconus stage 2, accelerated cross-linking was performed and referred after 2 weeks of procedure. Here we also do not have any inflammatory reaction in anterior chamber, and we have multifocal sterile infiltrate shown in the picture, and patient received steroids treatment with tapering, and 6 weeks after the treatment we have scars, and they are still there and interfere with vision. Also, cross-linking can be a trigger for herpetic disease reactivation. Usually risk factors considered epithelial abrasion, UV exposure, use of topical steroid drops, stress, etc. And most of people do not mention any previous herpetic disease in the eyes. So the fourth case, 21-year-old male presented with progressive bilateral keratoconus, accelerated cross-linking was performed, and on the 6th day he shows slowly epithelialization, and on the 10 days after we found unusual epithelial defect, and PCR was positive for herpetic disease. Patient was treated with acyclovir 40 milligrams 5 times per day, and after 7 days we have totally healed cornea. You see the mild anterior stromal scar left there. Infectious keratitis after cross-linking are a big issues. The majority of post-operative infections presented within 5 days following the procedures, and the common agents are staphylococcal and streptococcal species, but fungal and acanthamoebal keratitis also have been reported. Risk factors here we have epithelial defect, use of soft bandage contact lens, and topical corticosteroids. The first case with infectious keratitis is a young male with progressive keratoconus who underwent accelerated cross-linking 3 days after procedure. We have stromal infiltrate, melting, central thinning, pending to perforation. Corneal culture were positive for Candida and streptococcal species, and patient was treated based on sensitivity to antibiotics and antifungals. With amphotericin B, we prepared usually eye drops from injectable amphotericin solution, tobramycin eye drops, and tetracycline ointment, as well as cycloplegic and doxycycline for MMP inhibition. And here you can see the same patient after 6 weeks of treatment with anterior stromal scar left there. And the last case, also infectious keratitis, 23 years male, who had 5 days later, he was referred with stromal infiltrate, melting, corneal thinning. The culture was positive to fusarium. Here you can see the photo of the case, and if you notice, there is some satellite lesions. They are classical for fungal keratitis, and we have hypopion level there, and those are satellite lesions, the classical findings for fungal keratitis. The patient also was treated with sensitivity-based treatment, amphotericin B eye drops, fluconazole subconjunctival injection, as well as cycloplegic and doxycycline. And here is the photo of the same patients after 6 weeks. We have here a mild stromal scar left, and he had not bad vision with this scar. And what are the main points? That cross-linking is a choice of treatment for keratoconus. It is safe and effective method, but complications are rare but not uncommon and can be challenging for physicians. And the key point of treatment is systemic approach and early recognition of complications. So thank you, and you are welcome for questions.
Thank you very much, Dr. Davtyan. It was a very interesting presentation about complications. They are very rare, but we see these complications and we need to manage it. And the next presentation will be done by Mariam, Dr. Baghdasaryan Mariam. She will present interpretation of risk factors of ectasia after keratorefractive surgery.
Զեկույցս ես նույնպես կներկայացնեմ անգլերեն լեզվով. And so my talk is about interpretation of risk factors of ectasia after keratorefractive surgery. Corneal ectasia after keratorefractive surgery is a complication characterized by progressive corneal thinning and bulging, which all of us understand can cause to significant visual loss. While most patients who develop post-LASIK ectasia present identifiable risk factors, especially preoperative changes on corneal topography or tomography, ectasia in patients with normal preoperative tests is still a mystery. The phenomenon of post-LASIK ectasia was first reported by Saylor in 1998. They described case reports of patients after LASIK with progression of myopia and rapid progression of central steepening, which they classified as keratectasia. Approximately 50% of the cases occur within the first year, and up to 80% of the cases show up to within the first 2 years of surgery. It is more prevalent in males with younger age and higher myopic patients and thinner corneas. There are few reports that estimated that 4% occur after photorefractive keratectomy, while 96% of causes occur after LASIK procedure. Here you can see the absolute and relative risk factors for developing keratectasia. Now I'm going to talk more detailed about the relative risk factors. In corneal refractive surgery, detection of mild form of ectasia preoperatively is essential to avoid post-op progressive ectasia. And separation of high-risk individuals who may experience corneal ectasia after LASIK from patients who can undergo the procedure safely is of crucial importance. And this complication may occur in patients with or without pre-existing clinical evidence of form fruste keratoconus. Refractive surgeons try to minimize the potential for ectasia by leaving a minimum thickness of cornea in place, which is good for the large part, but it is not entirely satisfactory because the biomechanical properties of the corneal tissue for each patient are unknown, and thickness is not strength. On the one hand, they may be soft corneas, which may require a larger residual stromal thickness than normal corneas, and on the other hand, they may be hard corneas, which may tolerate more aggressive ablation safely that current guidelines for residual thickness allow. So what is the main causes of keratectasia? It's a residual stromal bed following surgery thinner than expected, preoperative pre-existing anomalies, undetected topographic abnormalities. And of course, the main cause is the biomechanical properties, poor hysteresis, low corneal resistance factor, and which we not take into account over these years, but by evaluating these properties, we can have much less ectatic disorders problems. Here you can see a few topographic maps and with asymmetric bow tie with inferior steepening, with superior steepening, and symmetric bow tie with skewed radial axis. And in these cases, we should be very, very careful to treat this type of corneas. Roberts and Dubs suggest a biomechanical modification after LASIK is focal in nature, and evaluating biomechanical strength of keratoconic corneas with brilliant microscopy also found that mechanical loss was focal, primarily concentrated within the area of the cone. And this focal reduction in elastic models results in biomechanical decompensation, initiating a cycle of increased strain, stress redistribution, and subsequent focal steepening and thinning, which actually lead to ectasia. So LASIK contributes to the risk of developing ectasia because it reduces the biomechanical integrity of the cornea, as its effective thickness is reduced after flap creation. And the anterior 40% of the cornea has been observed to demonstrate greater tensile strength because a greater density of keratocytes has been found in the anterior stroma than the posterior. And thicker flap creation isolates the obliquely running anterior stromal layers in the flap, leaving behind an inherently weaker corneal stroma. So if the residual stromal bed is thicker, it does not mean that we couldn't have ectasia after surgeries. Randleman and proposed the ectasia risk score system, which stratifies patients into different risk of ectasia. according to the number of preoperative parameters present. The parameters are topographic pattern, residual stromal bed thickness, age, central corneal thickness, and mean refractive spherical equivalent. And patients who are presenting 2 or fewer points would be at low risk of developing ectasia, and patients with 4 or more risk points would be at higher risk of developing ectasia, and performing LASIK should be discouraged in these cases. Regarding the tensile strength of the cornea, it is not uniform throughout the central thickness, with progressive weakening in the posterior 2/3. This influences the degree of biomechanical impairment after refractive surgery, with flap creation and ablation depth playing a significant role in postoperative weakening. Santiago proposed a new metric for calculating the ectasia risk in patients who are undergoing LASIK procedure. It is a percentage of tissue altered, PTA, a new significantly validated risk factor. And this metric is derived from the following equation. Flap thickness and ablation depth divided to central corneal thickness. And there are many reports that shows that is considered that high PTA, especially above 40%, is significantly associated with the development of ectasia. And sometimes PTA could be more important than residual stromal bed thickness. And PTA is considered to be an effective predictor of the risk for post-LASIK ectasia, especially in eyes with normal topography. And it is also an important additional indicator in eyes with preoperative abnormalities. So, in conclusion, also several risk factors have been identified for the likelihood of ectasia development after refractive surgeries. Some cases have been reported to develop in an enigmatic way without the presence of any of these risk factors. Some authors, as I mentioned, have proposed issues such as optic treatment diameter, percentage of ablated tissue, and corneal warpage as risk factors. Yet others have considered a low hysteresis as a predictive index of a pre-ectative condition. So ectasia remains a rare yet feared complication of refractive surgery. The presence of a validated risk scoring system and new diagnostic modalities to aid in the risk detection will hopefully decrease incidence of ectasia after LASIK. Thank you.
Thank you. And the next presentation will be by Gohar Alexanian. She's just graduated with excellent former resident. So, and present iatrogenic ectasia.
This is very important for our young generation, for young ophthalmologists, for residents, and of course we have here medical students that now we have 3 presentations, last 3 small presentation that was prepared by clinical residents in ophthalmology. Now, Gohar, it's your turn.
Hello, everybody. I will be short, but before I will be short, I would like to thank all of the organizers, especially Professor Artaşa Zilfian, for gathering us all together here, for giving this huge opportunity for raising the awareness about the keratoconus. And I will try to be short, as I will be presenting the same topic as Dr. Baghdasaryan, but I will try to cover the pieces that I find especially important, and maybe that will be some kind of new. So my intentions were to cover the actuality of the problem, the causes of iatrogenic ectasia. I will compare the iatrogenic ectasia and keratoconus. They are biomechanisms, immunohistology, and maybe the clinical too. Also, I will go short through the risk factors and the formulas to predict iatrogenic ectasia, and a little about treatment. As Dr. Baghdasaryan said, it is one of the most feared complications of especially refractive surgery, where the patient anticipates the most out of the surgery, and it is a little bit hard to talk to the patient when after a year or maybe 2 or even after a month, patient develops myopia and astigmatism that cannot be corrected through spectacles or any other kind. So it is very rare, 0.02 up to 0.6%. And when we try to compare the photos of keratorefractive surgeries, and we take 100,000 eyes that have gone through some kind of surgeries, we would find out that the least dangerous or the most safe photorefractive surgery is the small lenticule, small incision lenticule extraction. It will have only 11, and photorefractive keratectomy will have 20, and LASIK will have the most complicated eyes that will have approximately 90. So what is very important, that this complication is irreversible, so it cannot be changed, it cannot be we cannot come back to the initial stages, initial visions, and very often the myopia is even higher than it was before preoperatively, and the astigmatism is also unpredictable. So what happens is primarily the remodeling of the corneal surface when it bulges, when it stiffens, and the most important part that is the histologic and ultrastructural changes in predisposed cornea. So we have discussed already that there are 3 scenarios when something can go wrong. First of all, it is there are already weakened corneas with predisposed keratoconus that go through photorefractive surgery. Secondary, there are weak corneas but that have no clinical manifestations, and third are the group of patients that have no clinical or topographic or some kind of changes in their corneas, but still after maybe month, maybe year, maybe 2, they can still develop iatrogenic ectasia. So the main curse of it is that the histologic and ultrastructural changes, specifically the intralaminar and intrafibrillar biomechanic slippage induced by excimer laser distortion. What does that mean? That the collagen fibrils that are lying very strict, very precise in the cornea tissue, we know, are getting more thin, and the distance between them is getting larger and larger. That is what causing the thinning of the cornea. And also we cannot forget about the intraocular pressure that is like pushing from the inside the eye and making the bulging and stiffening even more. So let's compare a little bit the keratectasia and keratoconus. Thus, they are similar. Thus, they both cause lowering decreased visual acuity. They both have stiffening. They both have very fearful complications. They still differ them between one another in the structural and biomechanical and immunohistological etiology. So up there is written, the left column is written keratectasia, and the right one is about the keratoconus. So when we are talking about the keratoconus, we know that there is a distortion of a Bowman membrane because of the upregulation of the transcription factor SP1, also the decreased impression of other factor called alpha-1 proteinase inhibitor, and also the upregulation of the matrix metalloproteinases, especially MMP9. So all this is causing the distortion and thinning, and the cornea is becoming weak and protruding to the anteriorly. And when we talk about the keratectasia, we have no such kind of fermental or fermental changes. Instead, we have upregulation for the antibodies against A1-PI. Also, their main feature is the ultrastructural changes of the tissue of the cornea. It is decreased interfibril distance and collagen fibril thinning. So there are still collagen fibrils, but they are becoming thinner and thinner thanks or due to excimer laser distortion. And because of this thinning, also the distance between fibrils are getting enlarged. Some researches were done to find out that MMP9s are still active, not all the kinds that are present in the keratoconus, but some kinds are still active in the corneas that develop keratectasia after photorefractive surgeries. This may be also talking about that not all the corneas are predisposed to keratectasia, but there are some factors that we cannot observe every time, examine every time, and do maybe MMP9 or some other types of MMP. You know that there are MMP1, 2, 3, 9, 11, etc. So the main curse of it is that we have to cover all the risk factor. We have to make sure that we have done all the observations, all the examinations. We have covered thoroughly the history of the illness. We have to ask the patient about his siblings, or maybe mom and dad, about the keratoconus or form first keratoconus, or maybe even ectasia after the photorefractive kerat surgery. So also we have to be sure that the residual stromal bed and the flap thickness and the percentage of tissue altered will not be as high, to make sure that there are lesser and lesser risks of getting this feared complication. So we have already covered this with Dr. Bakhtasaryan. I will not stop on it. So this one too. We will go on to the treatment of the iatrogenic keratectasia. It depends on the stage, and it depends on the thickness of the cornea. In early stages, there may be possible implantation of the corneal lenticles. Also insertion of the intrastromal corneal rings that will stabilize the cornea. Also, if there will be if the case will be severe, there will be maybe better to go for a deep anterior lamellar graft, maybe, and to make sure that the patient will have more or less corrected vision, we can go for soft and rigid contact lenses, maybe scleral contact lens. And of course, I cannot mention the golden standard, maybe treatment of the keratectasia and keratoconus, of course, epi-on and epi-off, accelerated, non-accelerated cross-linking. So as a conclusion, we have to, as I have already said, we have to cover all the history of the illness. We have to count everything. And after that, if still keratectasia develops, we have to keep the patient under dynamic control and expose, I can say like this, the iatrogenic keratoconus as soon as possible to suggest the most effective, the most safe, and the most effective treatment for these patients. Thank you very much. This is all from me.
Thank you for nice presentation. And next speaker is Lucina Sumbulan, 30-year resident, and she will talk on corneal biomechanics and keratoconus. But slowly, yes.
Yes, first I'll try. So today we'll talk about corneal biomechanics and its connection to keratoconus. So the relevance of corneal biomechanics and its role in the clinical assessment of corneal ectasis are being increasingly recognized. The connection between corneal ultrastructure, its biomechanical properties and optic function is exemplified by a condition called keratoconus. So what we do need to know about the cornea, that the cornea is not plastic, it's viscoelastic, it has viscosity and elasticity. And what does it mean? Elasticity is the ability of a substance or a body to deform reversibly under the stress, and viscosity is a measure of its resistance against a progressive deformation. One more index that we need to know is the stiffness, which describes cornea. It's a measure of the resistance against elastic deformation as a response to the applied force, which depends on three major factors. That is the material, that is the thickness, and internal pressure. So, for example, if we compare the basketball to a beach ball, the basketball is harder to deform. Why? Because the basketball is made from the harder material, it's thicker, and it has higher internal pressure compared to the beach ball. And if we to think about the cornea, the material here is the corneal biomechanics, the thickness is, of course, corneal thickness, and the internal pressure is the intraocular pressure. So thanks to its regular formation, cornea is transparent and has higher refractive index. Its stroma accounts for 90% of total corneal thickness, and it consists of from 300 to 500 bed-like lamelles with fibrillar collagen type 1 fibrils and ground substance, which is presented with non-fibrillar collagen and proteoglycans. Anterior lamelles are randomly interwoven, thin, and anchored into the bone mass membrane, whereas towards the posterior 2/3 of the cornea, they are taking the orthogonal directions in inferior, superior, nasal, and temporal directions, and adopting stacked plywood-like organization. In posterior lamelles, there are wider, thicker, less densely packed, and highly organized. And these differences between anterior and posterior stroma give us biomechanical consequences. Anterior stroma has higher cohesive tensile strength and is less readily to swell, whereas the posterior stroma helps cornea to resist the intraocular pressure and contain its adequate corneal curvature. So collagen fibers are providing a cornea with elasticity and stiffness, whereas ground substance provides it with viscosity. Other stromal elements lead to give stroma the heterogeneity. So if we have a focal loss of elasticity, it leads to the corneal softening and then to the corneal deformation. I will not stop there because we already know what is keratoconus. So during the corneal ectasis, what happens in the cornea? In anterior stroma, there is less interlamellar adhesion, loss of interwoven pattern, and they insert more rarely into the bone mass membrane. In posterior stroma, the lamelles are there are lamel thinning, splitting, and distortion along with walked stria that run anteriorly from deep posterior stroma. There's also thinning and fragmentation of bone mass membrane, thickening of the
epithelial layer to fill the void left by the shrunken stroma. And in the end stages of the disease, there's a rupture of the Descemet's membrane and hydrops. So the mechanical theory of the keratoconus suggests that repeated excessive stress can lead to the biomechanical failure of the cornea. Stress can activate two predominant mechanisms like fiber breakage and interfiber cross-link breakage. And it's possible that the accumulation of this cross-link breaks can lead to the fatally weakening of the cornea and its cone-shaped, induce its cone-shaped protrusion. So I just wanted to add that in the pathogenesis, there are factors like increased expression of MMP1 and MP9, oxidative stress and inflammation with expression of interleukin-1, 4, 5, 6, and tumor necrosis factors, which also leads to the collagen fibers disorganization or ground substances disorganization. Here, I just wanted to mention that lately there's a popular method to analyze corneal biomechanics called Corvis-ST, which is presented with 6 graphs. I will quickly just mention them. The first one is the deformation amplitude, which is used to describe the cornea's softness. The second one is the applanation length, which is used to describe cornea's smoothness. The third one is the corneal velocity, which gives us tells us about cornea's ability to bend and curve. The fourth one is the arc length, describing cornea's elasticity. The fifth one is the DA ratio, which is used to describe cornea's stiffness. And the sixth one is the inverse concave radius, which is reciprocal of the inscribed radius curvature of the cornea. So in conclusion, what I want to say that biomechanical instability is seen as the underlying basis for the secondary morphological changes in the cornea, which can lead to the progressive ectasis. Conical deformation and corneal thinning are caused mostly when the mid-posterior stroma is affected. And what's important to know that the evaluation of the corneal biomechanics can play a big role in the early diagnosis of subclinical keratoconus and help us to stop the progression. Thank you.
Thank you for a great presentation. And the last presentation for this session, it will be done by Armenia Skandaryan, third-year resident, and she will talk about eye rubbing as a risk factor of keratoconus.
Okay, this is our final talk for this session. If you are ready, Armenia, we would like to hear your presentation. You can start already.
Yes.
Okay.
Ողջունում եմ բոլորին։ My topic for today's presentation is eye rubbing as a risk factor for keratoconus. Keratoconus is the most common corneal ectatic disorder, the cause of which is largely unknown. Many factors have been implicated, and the ocular allergy is one of them. The commonly proposed pathogenesis includes the release of inflammatory mediators to eye rubbing, which may alter the corneal collagen and lead to corneal ectasias. Control of allergy and eye rubbing as is the best measure to prevent corneal ectasis in cases of ocular allergy. Keratoconus is a clinical term used to describe a condition in which the cornea assumes a conical shape because of thinning and protrusion. The various of ocular allergic conditions that have been associated with keratoconus includes vernal keratoconjunctivitis, atopic keratoconjunctivitis, and seasonal allergic keratoconjunctivitis. Keratoconus is characterized by progressive progressive stromal thinning as a result of increasing expression of lysosomal and proteolytic enzymes, decreasing concentration of protease inhibitors, which results in altered collagen configuration. In allergic conjunctivitis, when specific allergens are reintroduced into the body through the conjunctiva, it reacts with the allergen-specific IgE on the surface of mast cells or basophils, releasing vasoactive mediators. These mediators include inflammatory molecules like alpha and tumor necrosis alpha and interleukins. The risk factors of keratoconus include demographic factors, ethnic differences, genetic factors, and environmental factors. Abnormal eye rubbing could be secondary to bothersome symptoms such as dryness and itching. Atopy and ocular allergy disorders, mainly vernal keratoconjunctivitis, are strongly associated with rubbing-related complications, most probably itching and watery eye sensations that trigger the habit of chronic eye rubbing. Vigorous and prolonged rubbing may lead to establishment of corneal remodeling and ectatic disorders, such as keratoconus. Keratoconus development in rubbed eye can be caused by mechanical mechanism or corneal thinning and its loss of rigidity. Responses to eye rubbing may include increased corneal temperature, epithelial thinning, increased concentration of inflammatory mediators in the precorneal tears, abnormal enzyme activity, large intraocular pressure spikes. And now case report, keratoconus after vernal keratoconjunctivitis. A 12-year-old female patient has applied to medical centers and she complained of itching along with tearing, foreign body sensation, and performed routine eye exams. The results of biomicroscopy, Gand pupil is located on the upper tarsal conjunctiva, swelling of the bulbar conjunctiva, and superficial conjunctival vasodilation. Diagnosed varial keratoconjunctivitis. Vernal keratoconjunctivitis, also known as spring catarrh, is a rare but serious allergic disease affecting the eyes of young children. And after a few years later, the same patient complained that her visual acuity was decreasing, and visual acuity was 0.9 left eye and 0.2 0.9 in right eye and 0.2 in left eye, and based on the examinations, diagnosed left eye keratoconus and treated with customized cross-linking. And after cross-linking, visual acuity was 0.4 and vernal keratoconjunctivitis was repeated, treated with topical corticosteroids. And after 3 months, right eye visual acuity decreasing too, and visual acuity was 0.8 right eye and 0.5 left eye, and diagnosed right eye subclinical keratoconus and treated with customized cross-linking. And here we can see the final result of topography after both eyes cross-linking. Thank you for your attention.
Thank you very much. Again, very interesting presentation by our clinical resident. And if we have questions and answers from our friends who is in Zoom, we would like to hear them. If not, մենք կարող ենք հայերեն անցնել եւ մեր առաջի անգլիախոս սեկցիան կարելի է ասել որ ավարտված է եւ մենք ունենք հիմա ժամանակ հարց ու պատասխանի հարգելի գոլեգաներ, եթե կան հարցեր, շատ ուրախ կլինենք ձեր հարցերը լսել միմյանց եւ քննարկենք, որտեվ երկրորդ սեկցիան մենք ունենալու ենք մի քիչ ուշ, այսինքն ընդմիջումից հետո։ Կան հարցեր, թե չկան հարցեր։ Եթե կան, խնդրում եմ ակտիվ մասնակցեն, ես կուզեի նաեւ կլինիկական արձինատորները մասնակցեն, եթե կա ցանկություն, մեր առաջատար մասնագետները, եթե կա հարցեր, խնդրեմ։ Ձեռք բարձրացրեք, ով ունի հարցեր։ Առաջի սեկցիան մեր մոտ այսօր նվիրված էր հիմնականում կոլեգաներ, հիմնականում կերատոկոնուսի ոչ միայն տեսակների մասին, այլ կերատոկոնուսի կորեկցիայի եղանակների մասին, վիրաբուժական կորեկցիայի եղանակների մասին, եւ մենք հատուկ այդպես էինք դասավորել, որ մեր արտասահմանյան սպիկերները խոսեին հենց կերատոկոնուսի բուժման մասին եւ տենց էլ եղավ բավականին հետաքրքիր պրեզենտացիաներ լսեցինք Իսրայելից, պրեզենտացիաները Վրաստանից, Ինդիայից, վիրաբուժական հետաքրքիր մեթոդների մասին եւ իմ կարծիքով շատ հետաքրքիր էր եւ կարելի է ասել, որ այս առաջի սկիզբը մեր մոտ բավականին լավն էր եւ պրոդուկտիվ։ Երկրորդ մասը մեր կոնֆերանսի նվիրվելու է արդեն հիմնականում նվիրվելու է կերատոկոնուսի կորեկցիայի, հենց կորեկցիայի մասին, մենք ունենք սկլերալ լինզաների մասին հագին information, մենք ունենք կոնտակտային, մենք ունենք էլի քրոսլինքինգի մասին աշխատանքներ եւ ես բոլորին կսպասեմ երկրորդ սեկցիային։ Ուրեմն այս պահին մենք կարող ենք, եթե հարցեր արդեն չկան, հայտարարենք ընդմիջում եւ ընդմիջումը լինելու է մեր ժամը եկեք ֆիքսենք, որպեսզի քանի որ մենք ունենք եւս քանի պրեզենտացիա, եւս 20 պրեզենտացիա մենք 20-ին մոտ ունենք պրեզենտացիա, քանի որ այտենց ստացվեց, որ Keratoconus մեր ասոցիացիան շատ ակտիվ էր, մի րոպե սպասեք, մի գնացեք, ես էլ եմ սոված, բայց եկեք ժամ ֆիքսենք, ժամը 2-ին մենք ինձ թվում է 2-ին, 2-ից մաքսիմում 10 հավաքվում ենք մեր երկրորդ սեկցիային, որ արդեն կնվիրվի այդ թեմային, խնդրում եմ օգտվեք lunch box-երից, որոնք ստեղ տեղադրված են եւ ժամը 2-ին հավաքվում ենք երկրորդ սեկցիային, բոլորի շնորհակալություն։